absorption and is the unique differentiator for all QuikClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuikClot products have a track record of success, starting in the military as the hemostat of choice. QuikClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuikClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, apply directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Route the band between the clips and over the rod. Secure rod and band with time strap. If able, record time of application on the time strap with the permanent marker included in the kit. Combat Application Tourniquet, CAT, storing the CAT in the quick launch configuration. Take the band out of the buckle. Ensure the rod is not secured in the clip and all turns of the rod are removed. Stretch out the band twice, horizontally, like an archer, to straighten it out. Pass the red tip through the slit in the buckle. Pull 8 inches of the band through. Fold it back and adhere the band to itself. Flatten the loop band. Place the buckle in the middle of the flattened band. Fold the CAT in half, placing the buckle at one end. Secure the rod inside a clip to lock it in place. The CAT is now ready to be used for future training. These are some important points to remember. Never place a tourniquet over a joint, such as a knee or elbow. The tourniquet can be applied over clothing. If the site of the bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible, on the injured limb. Never use the tourniquet over items in your clothing. For larger-limbed persons, 2 tourniquets may be used, but must be applied side by side, with the rods not interfering with each other. Once again, the band should be tight enough that the tips of 3 fingers cannot slide under the band.
Dr. Faith, you may start now.
Good morning, everyone. Welcome to the monthly online trauma series presented by the Malaysian Society for the Care of Trauma and in collaboration with the Southern Philippines Medical Center. Let us all be in attention for our prayer.
We are grateful that you are God, that you are in control. Nothing is impossible with you, Lord. We ask that you will grant us all the wisdom, the patience, the endurance, and sensitivity for the days and weeks to come. We pray for the sick, O Lord, for every person who is currently infected. Please do not allow this condition to advance further or become dangerous. Heal them, O God, completely. Give them the courage, the strength, and grace to face it. We pray for all the health workers. We pray for those who are in the front line treating the sick, that you, O Lord, will protect and strengthen them. We pray for divine inspiration for the medical researchers to invent medications, vaccines, and therapies for this. We also pray for those who are vulnerable to the disease, that the sickness will pass over them, even for those who have not been exposed. Put a shield of protection around them and give them the wisdom how to avoid it. We also pray for those who are unemployed, affected during this crisis. We pray for those who have lost their work, that you, O God, will provide for their family supernaturally. We also intercede for our national and local leaders, that they will have the wisdom to do what is best for all and not for their own interests. We pray for the students who are out of school and parents, that the Lord will give them the patience and discipline to become productive while being quarantined. We pray and apply the blood of Jesus to protect and cover, that no virus will touch and cover the dwelling of each family. We pray also for everyone who has already lost a loved one, that you, O God, will comfort them. We pray for the churches, the family, the pastors, and the cell leaders, that their faith will be firm and have a desire to grow in God, and that they will increase in the knowledge of you, Lord, and allow them to show the love of Christ in this time. We pray for the Philippines and our city. We pray that our nation and city, that you, O God, will bring healing and deliverance from this pandemic. This we ask through Christ, our Lord and Savior. Amen.
بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. In the name of Allah, most gracious, most merciful. All praise is due to Allah, the Lord of the worlds, the most compassionate, the most merciful, Master of the Day of Judgment. You alone we worship, and you alone we ask for help. Guide us to the straight path, the path of those you have blessed, not of those who have incurred your wrath, nor of those who have gone astray. Bismillah ar-Rahman ar-Rahim. Qul Allahu ahad, Allahu samad, لم يلد ولم يولد ولم يكن له كفوا أحد. In the name of Allah, the Merciful, the Compassionate. Say, He is Allah, the One and Unique. Allah, who is in need of none, and of whom all are in need. He neither begot any, nor was He begotten, and none is comparable to Him. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. Our Lord, give us in this world that which is good, and the hereafter which is good, and save us from the torment of the fire. Walhamdulillah Rabbil Alameen.
Let us all stand for the national anthem of the Philippines. I'm sorry, for the national anthem of Malaysia. Let us remain standing for the national anthem of the Philippines.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, helas ng silanganan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyag ka ng magiting, sa manlulupin, di ka pasisigil, sa nagatak tutok sa simoy at sa langit mong bagaw, ay hinatang tula, kawin sa paglayang minamahal, ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan pa may di magtitindig, lupa ng araw ng walhagin pagsingka, buhay langit sa piling mo. Aming ligaya na pagkay mga amin, ang mamatay ng dahil sa'yo. Mga
Good morning, everyone, and welcome to the 11th webinar of the Malaysian Society for the Care of Trauma in collaboration with the Southern Philippines Medical Center. Before we start, I would just like to remind everyone of our house rules. Kindly keep your audio and video turned off while talks are ongoing. For optimum audio and video experience, please ensure that your internet speed bandwidth is adequate. And in accordance with the Data Privacy Act, recording of lectures or any part of the program is strictly prohibited. Kindly type your questions for the ongoing lecture in the chat box. Attendees must accomplish the evaluation form through the link that will be provided in the chat box in order to receive your certificate of attendance. And most of all, enjoy listening, and we welcome your active participation in the Q&A sessions. To open our program this morning, we'd like to hear from our chair from the Southern Philippines Medical Center, Department of Emergency Medicine, Dr. Benedict Edward P. Valdez, for his opening remarks. Dr. Valdez. Dr. Shah, the virtual floor is yours.
Hi, good morning. I hope can you hear me, Faith?
Yes, sir. Your
Yes.
audio is clear.
Thank you very much, Faith. And I'd like to wish everybody a very good morning, and thank you to all participants for sharing the time with us on a weekend morning. And on the behalf of Mascot, we'd like to welcome everybody. And for our 11th monthly trauma series for the year 2021. And this month we have a special regional edition with our twin sister partners, the Southern Philippines Medical Center, when we are co-organizing this event for all of you today. We have a lineup of very credible speakers from both the regions to bring you half of the mornings or half of the afternoons session till 12 o'clock, as well as we'll also take this advantage to commemorate the Memorandum of Understanding, MOU and MOA, between the Southern Philippines Medical Center and also the UITM Trauma Services in collaborating on the subspecialty trauma vision training program. So once again, I thank all participants for being with us. And last but definitely not least, the organizing team for making this event such a success from both the SPMC as well as from the mascot group. So thank you very much, Faith. And back to you, and please enjoy the day. Thank you.
Thank you, Dr. Shah, for that very wonderful opening remarks.
We welcome you all the participants and guests to this monthly online trauma series. And this is a collaboration between the Malaysian Society for the Care of Trauma and the Department of Emergency Medicine, Southern Philippines Medical Center. We are lucky to have our partners here with our Malaysian counterparts, and we conducted this series of symposium to enhance and improve capacity building among partners. So we welcome you all to this forum. Thank you and good day.
Thank you very much, Dr. Valdez. I know everyone is very excited to hear our lectures for this morning. So let us start with the topic of special considerations in trauma involving women and intimate partner violence. Our speaker had her residency training in emergency medicine at the University of the Philippines, Philippine General Hospital. She's master's in community healthcare management and is currently finishing her degree in health promotions education at the UP College of Public Health. Presently, she is the training director of the Department of Emergency Medicine at Corazon Locsin Montelibano Memorial Medical Center and the head of the resuscitation section of the Manila Doctors Hospital, coordinator for telemedicine of the Southern Philippines Medical Center, an immediate past president of the Philippine College of Emergency Medicine, and a member of the Gender and Equity and Equality Committee of the International Federation of Emergency Medicine. Let us all put our hands together for Dr. Pauline F. Convocar. Dr. Convocar, the virtual floor is yours. We are just waiting for Dr. Convocar to share her slides.
Good morning, everyone. Just give me a moment, please. Okay, can you all see my slides?
Yes, Dr. Kanbakar, we can see your slides.
Thank you very much, Dr. Faith, for the very warm and kind introductions. And I'd like to also welcome everyone to our meeting today. I hope this may just be some sort of an personal and an informal discussion, because I'm also very new to the topic that was assigned to me, but which is very close to my heart as well. So anyway, the topic that was assigned to me is trauma management in women and intimate partner violence. So I'm quite new to this topic, but let me just see if I can also give justice to the topic that was assigned. So welcome everyone. I'm currently broadcasting from the hospital. I'm from duty. So kindly also just bear with me. So I don't have any significant disclosures of interest. Don't have any conflicts of interest to disclose. But let me start with the story of our Philippine legend. We have a legend of the how the first woman and the first man, or the first Filipino and the first Filipina came to be. So we had here si Malakas at si Maganda, or the strong and the beautiful, which is a Philippine creation story. So as you can see in this particular story, we are very much grounded and very much, we really do have some stereotypes. So we see the man as malakas or strong, and the woman as just beautiful. So there's really just this stereotypes of how we view our differences in gender as a Filipino people. But in the current events that just happened, we used to say, kababae mong tao o kalalaki mong tao, which is like stereotyping, saying certain occupations and certain sports may necessarily be associated with certain gender stereotypes. So we just had our first ever gold from the Olympics, which really breaks this gender stereotypes. So I also would like to share somehow a bit of a global picture of the prevalence of violence against women, but we also know that violence against intimate partner violence may not necessarily just be about violence against women. So across the globe, regardless of if the region is of low and middle income countries or high and middle income countries, it's really quite prevalent. It's roughly around 25 to 30% in each of the region, which translates to around 1 or 2 to 3 in every 10 persons in a population. And violence against any individual really have great health impact. So with women that are exposed to intimate partner violence, they are twice as likely to experience depression, and they are twice as likely to have alcohol use disorders, and 16% more likely to have low birth weight baby, which really have an impact on the health outcomes as well of the babies. Death and injury occurs in about 42% of women who have experienced physical or sexual violence at the hands of a partner, and 1.5 times as likely to have sexually transmitted infections. We also know that around 40% of all murders of women globally were reported as being committed by their intimate partners. So that's the gravity of the health impact of violence against women. So it is imperative that we as healthcare providers should also be able to really immediately recognize that there is a problem and we should talk about it. At least 1 in 4 women, and since men are not excluded, 1 in 7 men are victims of severe violence from a partner at some point in their life. And these are not just limited to some physical abuse, sexual abuse, or psychological abuse, but also includes just by mere stalking. So we have to really be cognizant, and we have to be part of a multifactorial, multi-sectoral, multi-level interventions to be able to address this issue, which is deeply rooted in our history and deeply rooted in, of course, in our sensitive cultures. So these are just some forms of intimate partner violence, which may not just necessarily be physical trauma. It may also be psychological trauma and stress and fear and control. So when I was trying to research more about what trauma management in intimate partner violence, most of the readings that came up were actually about trauma that are non-specific and actually are more psychological trauma. So I really had some sort of difficulty looking for literature on physical trauma alone related to intimate partner violence. And interestingly, in some of the references, most of the reported injuries are actually ophthalmologic in nature and maxillofacial injuries. So you can see here the profile of the features of the physical trauma, which are basically a blow to the face or a hit on the face of the intimate partner. So here, the physical injuries may be musculoskeletal, soft tissues, genital trauma, and many other things. So when we see patients at the hospitals, be it a man, a woman, or any gender, we have to also see these things in a spectrum. And we have to prevent all of these, of course, to have poor outcomes, or like it may develop into a disability or even leading to death. So we have to see the entirety in a spectrum. So in the Philippines, of course, we are considered a middle-income class country. Although we've had many policies and laws in place, some of our people are still very much silent about violence among intimate partners or between intimate partners. So this is the number as reported by the Philippine Statistics Authority. Apologies for the very small infographic, but this, you can see really that a greater number is about physical violence only, or considered also together with a sexual violence incidents. And you can also see the intervention of the government or the interest of the government to decrease, of course, all of these cases. So we've had our VAUC desks, or violence against women and children desks, all across the country, and this has already been mandated by the government to be established in all of the government units. So this is one interesting observational study that was done where 25% of married women who reported experiencing some form of violence from their partner. But this here in this particular report, you can only see that 10% of them actually sought medical or legal help. So we also need to be understanding when a patient arrives at our emergency departments or in our institutions that it took them really a great amount of courage to present themselves at the ED, and their presentations may really be very sensitive. So formal health seeking rates were very low among victims of intimate partners in the Philippines, or intimate partner violence in the Philippines. And it will take them a very severe kind of presentation of abuse that may lead them in seeking legal or medical help. So we need to be culturally sensitive. We need to have competent providers and increase our capability to be able to address all of these needs of our patients. And efforts should be made to increase the formal health seeking behavior among the victims of our patients of domestic violence. So this infographic just shows the entry points of patients in our institution. So you can see here it's quite really extensive, and Southern Philippines Medical Center down here in the south is one of the hospitals that have already established a women and children protection unit in the hospital. So we have a different track, or a fast track, or a different area where sensitive cases like this are attended to. So the succeeding slides are just snippets from other sources like the CDC, the American College of Surgeons, as to their developed guidelines and the infographics as well as to how we will be able to recognize as healthcare providers issues or patients with intimate partner violence history. So when you see a patient who's had physical injuries, we have to have high level of suspicion all the time, and always think that this may still be a product, or this may still be as a result of an intimate partner violence. Even some chronic conditions may present But in the presence of other injuries that may not be usual or in an unexpected places, we have to be very mindful and be very cognizant about the possibility still of negligence and abuse. So it may be even as simple, sorry about that. It may be even presented just as a sexual transmitted illnesses or even just urinary tract infection. We'll have to really investigate and ask if it's also, again, a product of domestic violence or intimate partner violence. So it's across a spectrum. And no specific chief complaint may even be pathognomonic of IPVs in this particular case. Just put that in mind that even if it's as simple as a headache or a chronic pain, they may still be parts of an IPV spectrum. So the WHO had a very extensive document that they posted in their website about how healthcare workers will be assisted or guided, and how we will be able to intervene each time. So every time we see a patient in the ED, that's already some sort, and we have a red flag, or we saw that there's a red flag, we have to have a cascade of activation of potential interventions in our ED as an entry point, or our WCPU. So we have to also be mindful that we should be, of course, competent and well-trained. We have our SOPs in place. Consultation should be done in private setting, and confidentiality is really guaranteed. If your facility may not be capable, or if there's no one trained to manage cases of VAUC or IPVs, then we need to have a referral system in place to ensure that women and victims of violence may still have access to other related services. So the healthcare settings should be really equipped to provide comprehensive response, addressing both the physical and the mental consequences of the abuse or of the injuries. And we have to have also, since these have legal implications, we have to have reporting mechanisms, and we have to gather evidences when needed for the conduct of the investigation for the case. So as a health sector response, since this is a spectrum, we may develop systems from the time, thinking also of the emergency care systems framework, from the time that the patient is recognized that it may be a possibility of an abuse or a possibility of violence, then we have to develop and to be guided that we have to be women-centered or patient-centered care. We have to identify some of the survivors and the victims, or IPV victims. No, I stand corrected. With due sensitivity, we should not call them victims, and we should call them, on the positive side of it, that we should call them survivors now and not victims. I apologize for that. I'm also learning here. So we also need to train our healthcare providers on of course, the case, and we have to put some policies and provisions in place, and we have to report. It's a compulsory reporting that we have to report this to the police. So to also address the spectrum, we have to also look at the factors why there is an abuse in the first place, or where there is violence in the first place. And we have to understand that there are not just medical factors or determinants of health, but many other factors like political, socioeconomic, even educational disparities or power gaps between the two partners. So we have to also address all of those things, so that the woman or the survivor may be empowered to be able to be sufficient and to get out of that violent relationship. So I've already stated this. So if an event happens here, we have to have a system that the patient may be able to brought to the definitive facility. But if not capable, then we have to have also referral mechanisms where we may transfer the patient to another facility capable of care, of giving care. So everyone has a stake, and we need to break the silence and stop the violence. So everyone, from our communities, as an individual, as an organization, and even as a country, and as a region, we have to develop our policies, we have to develop our collaboration to really stop this vicious cycle of violence. And just by speaking up or breaking the silence is the first is a start. So this is one table as was presented in the American College of Surgeons, and they've defined what IPV is. So since we've already stated that it may not just be physical and it may be also psychological or emotional abuse or even neglect, it is also an IPV. So who perpetrates IPV? Both sexes and all genders may also be perpetrators. They show near equal rates of IPV perpetration, although the women perpetrate at slightly higher rates, and men, however, have more frequent and severe physical injuries. But they do occur across age groups and across ethnic, racial, and cultural backgrounds. The risk factors for IPV were shown here, but primarily we can see here that there may be concomitant mental health issues, psychological issues, but there really is power gap between the intimate partners. So again, these are the components or presentations of physical and behavioral outcomes of IPV, but of course not limited to this in the table. So I got the advice from this site. So this is coming from the American College of Surgeons as a guide to the surgeons, but then of course we can also adapt it as emergency physicians to IPV, and especially that there's this increase of IPV in the era of COVID pandemic. So, sorry, I'll skip that part. So with the patients, actually with the patient demographics, they're the same. And the injury patterns, was not able to transfer here the infographic, but for the injury patterns, they're the same. They did not change, and there was this even increase in the prevalence of IPVs because we had to stay at home. So they had no choice but to really stay at home and be with the partner. So it's very important that we have to have mechanisms of detection and management in place. Apologies again for this. But let me just skip through my slides and present this very important table, which is a mnemonic of a screening tool when a patient presents at the ED. So Be Aware is a mnemonic from the bulletin of the ACS as a guide to recognize IPV patients. First, let's be educated on intimate partner violence and of course its sequelae. We establish contacts with our community-based agencies. We arrange the confidential environment with patients that are unaccompanied, so social service in case of the Philippines. We welcome discussion by introducing the subject of IPV, so let's not make it a taboo of not talking about it. We have to speak up, and by speaking up, it may now erase all the preconceived negative implications or the stigma that's brought by the IPV. We ask direct questions about the IPV and the patient safety. We review the resources and options for our referrals. And lastly, we endorse the patient's wishes on whether or not to take action. So the IPV protocol that they've presented or they've suggested are as follows. So they have these direct scripts that they may say when a patient presents to them. But I'm just interested also, of course, there may be some other tips or scripts as to how you'll be able to elicit really the IPV. But I'm particularly interested in the discharge safety. So at the end of the course, at the end of your intervention, you have to decide, is the patient admissible or not? Because even if the trauma may not be that significant or may not be that fatal or not be that serious, there may still be a threat to the life of the patient. So you have to make a decision if you'll discharge the patient by virtue of the physical management, but to where will you send off your patient? So we need to ask directly if the patient feels safe going home or the patient may be admitted in another facility for continuity of care. So this was one, actually, the slides that I wanted to show was about the some of the references we just showed, the ophthalmologic presentations and the maxillofacial injuries that were basis of recognition that there's IPV. So I think I skipped that slide. So anyway, in our previous meeting, in our previous discussion, I have presented a trauma team activation protocol, be it partial or full. So I'm challenging, maybe in Malaysia you already have, but in the Philippines, we are yet to develop our trauma team activation protocol, and maybe with our involvement with pre-hospital care, we may use of the TTA or trauma team activation protocol now involving uh, a pathway perhaps for potential IPV or potential VAUC. So even before the patient arrives at the ED, then we may be able to already inform our team that there is an incoming IPV patient. Okay, so I'm just showing you here the trauma care continuum. This is also in relation to that of our ECS. Because we've emphasized, of course, that if we do not recognize it, if we do not have data, if we do not have registries, we may have difficulty, of course, improving our system. So these are just the systems that are in place, and even pre-injury, we may already have interventions. Even in our pre-hospital or EMS part, we may already have our interventions for IPV. And definitely, of course, when the patient is already in our facility, we may do all of these things together with trauma center team activation. We may alert them. We may have separate triages specific for IPVs and many other interventions in our facility. And definitely after that, the post-acute care is the recovery phase where we have to have plans to reintegrate our patients back to their community. Also here is the references that I got where I specifically somehow emphasized that the reports really came from the EDs, and that this is from the ACS and the NCD references of some of the literature that they've searched. And you can really see here that most of the reports are maxillofacial and ophthalmologic complaints. The succeeding slide is an attempt for me to answer the question on do we have different care, or will we treat our IPV and domestic violence patients differently? So since they're trauma patients we still have to follow our own protocols as to clinical management of the physical violence. However, it should have a multidisciplinary approach to it, because there may be other, of course, cases when there really is sexual abuse, or they may be psychiatric sequelae of the abuse. So the approach still is that of an ABCDE approach. And of course, we got this from the basic emergency care course. And emphasizing that regardless of the cause of the trauma or the nature of the trauma, the management is still the same. So I'm actually nearing the end of my talk, but I just would like to present somehow the efforts of the Philippine College of Emergency Medicine to also advocate for gender equity and equality among us members as a society. So here you can see that we have an equal, somehow relatively equal numbers of male is to female gender distribution. And I'm just showing you here the distribution of the training institutions in the Philippines. I'll just skip through that. And these are all just numbers. Why am I showing this? Because just by seeing the gender distribution of our facilities and our residents, we may be able to profile the gender disparity among our institutions and our society and as a country, of course. So just many numbers that I'll present here. And here are the president leaders from the start of the merger of the society. So the first woman president is, of course, Dr. Faith Gerlan, my mentor, and the second one was me. But you can see the disparity as well in the gender distribution. That's only 2/7 of the women presidents. So again, just a few numbers that I'm sharing as part of our advocacy of seeing the gender distribution in our society. One important thing as well to develop awareness among us as members is just to look at your own profiling of your conventions. If you did study the data that how many male or female presenters that you invited to a convention. So you can see glaringly here that there's this really more men that were invited into some conventions of PSEM from the start of our society. So why do gender matter? Why does gender matter? Because it is a human right and it is the most significant determinant of health. And we need to be, we have to be very specific. We should recognize that we have to have equal opportunities for any gender in a workplace, and that's inherently really good. So we have to also have innovative ways to ensure that among healthcare professionals and how we will care for our patients, we are giving equitable and equal care to all. So non-discriminatory care and no gender bias. So these are the core values of the PSEM, and I just would like here to emphasize in this slide that we are for equity and excellence. And because of that, in our PSEM roadmap, we have identified some of those foci or our key strategic areas. And one of that really is to have equity, equality, and empowerment among our members. So we just had our GE awareness event. And these are the 10 actionable points. We wanted to have non-discriminatory patient care. So that is an application for trauma is that regardless if the patient is a woman, a man, or any gender, there should be systems in place that there should be non-discriminatory patient care. And down the line, which we will be addressing as part of our strategic roadmap. So we just had our workshop in collaboration with the Society of Emergency Medicine India, and of course with the task force of GEE also from IFEM, because as some sort of a statement, they wanted member societies, so PSEM is a member of IFEM, that we have to develop our committees and task force which addresses the spectrum of GEE issues. So what is included in that spectrum? Here, this includes again related to gender discrimination in patient care. So we have to address this, and we have to put in place really all systems that patients are attended regardless of their gender or their preference. So some of the other slides here are just some of the final slides, just showing you that we're very strong on advocacy. This is one of our conventions in PSEM, and then we had also some discussions as to, again, gender distribution here. So there you go. Thank you very much, and I hope let's do some more discussion as to IPV, and I'll be very happy learning with you. Thank you very much.
Thank you so much. Thank you so much, Dr. Kondakar.
I'll be happy to take the questions now, Ma'am Faith, or after the...
Just flash the questions for a while.
Oh, okay. Would you like me, Ma'am Faith, to read the question, or we will have a moderator?
Hi, Faith. Can you hear me?
Yes, Dr. Sabaria.
Hi, Pauline. Hi, Faith, and hi, Ben, and our Malaysian and Philippine colleagues. Sorry, my video is not working that well today. Right. Thank you very much, Pauline, for a very good presentation and to have an overview of interpersonal violence. I just it's just a comment. It's not a comment. It's what's happening in Malaysia, right? In Malaysia, we have what we call a one-stop crisis center. All emergency departments in Malaysia, especially those in the Ministry of Health, have to have one. So if any patients with interpersonal violence or rape or any child abuse cases, from the front end of the ED, from triage, they're directly brought to the area. So which means the treatment converges to the patients. the medical team, the emergency team, the obstetric team, and if need be make a police report, the police will go to that special area. And if a social worker is being called, they go to that area so that the patient is managed there. Right. So that was the one-stop crisis center was set up many years ago by that time Dato' Abu Hassan, right? And it's been on for in Malaysia and hopefully going on strong even through this COVID time. So probably Philippines could do something similar. It's just a small room away from everybody else, right? Where so that these patients are not embarrassed by the other patients waiting, because it's quite a stigma to them, right? As you have mentioned, right? So we put them in a separate area, in a separate room, and we do see this patient quite early. Thank you very much.
Thank you very much for sharing.
Thank you very much, Dr. Sabaria, for that. We have some questions from the chat box, Dr. Convocar. The first question is, in terms of handling women in intimate partner violence, what are your suggestions in terms of strategies for developing the skills among emergency physicians or doctors in the ED?
Yeah, it's an interesting question because we all know that the emergency department may not be a very good place to do our sensitive communication or how we will be able to elicit the IPV. So sometimes it's direct. I mean, it's there are red flags, and it's very direct that the chief complaint is that they will really immediately disclose. But for some cases when it is not direct, then it takes really a good amount of training and skills to elicit such history. So what we usually do is we send, of course, when we examine patients, especially women, we have to be really culturally sensitive. That's why we have to be culturally competent. There are also some trainings on that. We have to choose our words carefully because these are really good opportunities for us to elicit that there may be a history of violence. So you have to also be very meticulous about the physical examination because some injuries may be out of place. So when you see things like that, these are red flags, and you may somehow approach the patient and interview them apart from their partner, and just ensure that you have another colleague with you who will examine the patient with you. But for those who are really direct, or I mean, it's really clear that the chief complaint are those that it's IPV or domestic violence. We do have some pathways, as what Dr. Sabaria has said. We have a pathway that they are not mixed with the other ED patients that we have. So the only potential difference may be when they do not present themselves and they do not fully disclose that they are survivors of the abuse or the violence of their partners.
Okay, and there's another question here about probably who are the proper authorities who should be contacted when a victim seeks help but is still confined at home together with the abuser.
So in the facilities, when I used to be a doctor to one of our villages in one of our islands, we have what we call a one-stop shop, as what Dr. Sabaria has also said. So when we have a history of abuse, but the patient is still at home, we bring all together the three main persons or stakeholders who will have to do the case report. So we have the doctor who will physically examine the patient, and we also bring our social worker and the police. So we have a police desk or a women's desk in all of the police stations to be, again, sensitive about the issue. And then either of the three who will first recognize that there may be a case, then it is now that trigger to call on the other two, who should ideally examine the patient altogether, so that they will not be embarrassed or ashamed anymore to go from one area to the next. So when the police first detects then a doctor is called and the social worker is called. And similarly, if the case was recognized in the facility or the health facility, then the social worker and the police are called in the same spot. But it would really take someone to report first, or for the patient to go to a facility first to disclose that there is an event, or there was really violence, or there was this there was a case. So there you go.
Yeah, probably there is really a lot of public education that can still happen with regards to this issue. Thank you so much, Dr. Kanwakar. And allow me to present our certificate of appreciation to Dr. Pauline Kanwakar, who has contributed as invited speaker to the Mascot Trauma Series, CME, held this 20th day of November 2021, signed by the President of the Malaysian Society for the Care of Trauma, Dr. Jasahan Mod Yusof, and Dr. Nurul Asyan Norzan, Coordinator for the Mascot CME. Thank you so much, Dr. Konvakar, for your time.
Again, thank you very much, Ma'am Faith, and it's always a pleasure to join everyone here. Good morning.
And now we will take a 5-minute break before we continue with the next topics in our program. Dr. Norzan.
and welcome back, everyone. For our next topic, we have another interesting presentation on pediatric trauma, update on cervical injury management.
Sorry. Dr. Yap Xiao Ling is a consultant at the Pediatric Emergency Physician at Hospital Tunku Asisa, Kuala Lumpur, and completed a year of fellowship at the Hospital for Sick Children in Toronto. She is also involved in the National CPG for Pediatric Asthma, Pediatric Pain Management, Pediatric Life Support Manual, as a reviewer for many other protocols and guidelines. She is very passionate about improving child safety in and out of the hospital. Let us put our hands together for Dr. Yap Xiaoling.
Thank you, Dr. Faith, and good morning to all. Can I share my screen now?
Yes, please.
Oops, I think I pressed on something else. Okay, are you all able to see my slides?
Yes, we can see your slide.
Okay,
Thank
that's
you.
great. Okay, thank you to the organizers for inviting me to share on this topic. My name is Xiao Ling, or you can call me Dr. Yap, and my topic is titled Pediatric Trauma, Update on Cervical Injury Management. So I'd like to take you to somewhere in Malaysia. I work in the capital in Malaysia, Kuala Lumpur. So this is a typical hospital where a 3-year-old who just fell from a 5-story building coming in with major injuries require resuscitation and intubation. I'm sure in Philippines or in Malaysia, you would probably have this kind of scenarios happening, and you can see that you need many healthcare personnel compared to your adult resuscitation. So with that, I'm actually just going into my topic. I have no conflict of interest to declare, and this is the outline of my talk. I'd like to go into a fact number 1. Okay, so I like to always go to history, and I would like to just share with you that treatment for spinal cord injuries have always gone back to even prehistoric times. And interestingly, the pre-hospital spinal immobilization was introduced as early as in the 19th century during the Napoleon Wars. And thankfully, whatever is said, out of all the trauma injuries, C-spine injuries is rare, right? Even in the adult population, even more so in the children, especially those who are less than 5 years old, you can see the incidence is less than 1%. Having said that, any C-spine injuries, the sequelae is very devastating. In children, there's about 60% of these children will result in permanent neurological deficit, and about half of them will actually die because of a C-spine injury. Now, let's go back to the basics. We cannot, not know the anatomy, especially in children. So we know that children of the younger age would have a large head, and this will actually change the location of the fulcrum. An adult fulcrum actually is around the C5, C6 level of the vertebrae, whereas in the child, it's actually higher at C2 and C3. Just bear in mind all these considerations, because in my following slides and talk, I will be talking a bit more on that. And in children, the muscles and ligaments are generally weaker and more lax, and this can lead to further complications later on, as well as the vertebrate body. So they do not appear to be the same as your adult vertebral bodies, such as the anterior vertebral body is wedge-shaped for the children. Their intervertebral disc is more spacious, and their facet joints are more horizontal. And on top of everything, we have ossification centers that appears at different age group in children. And what does this mean? This means that, in the children, their C-spine injuries are usually the upper C-spine compared to your the adults, which is in the lower C-spine. And because of the laxity of the muscles and ligaments, they actually have an increased C-spine motion, leading to more soft tissue injuries rather than bony injuries, and they can actually have something called skiwara. I'll talk about it a bit more. Same goes with the vertebral bodies. So when does the child transition to an adult anatomy? That's about 8 years old. And what are the common causes of C-spine injuries? Now, motor vehicle accidents are always more common, and it's top on the list. However, just like how Dr. Pauline talks about violence in adults, in younger populations, especially less than 2 years old, don't forget traumatic injuries from non-accidental trauma can cause a C-spine injury as well. And as they go along to older age groups, spots can be also a predominant cause of mechanism of injury. Now, when we talk about initial management of C-spines injuries, spinal motion restriction is the same as in adults. You will do it only for those who are suspected to have C-spine injuries. It needs to actually happen from the word go at the scene, meaning at the pre-hospital care level. And it needs to be maintained all the way up till you are able to do a full assessment. Now, when do we actually suspect C-spine injuries? High-risk mechanisms such as a motor vehicle accident, fall from height, diving injuries. So that's one. Secondly, any patient who comes in with altered mental status or unconscious, who are unconscious, any child who appears to have torticollis, anyone who complains to have significant neck pain, or in your examination there's tenderness or there are local signs of cervical spine injuries. Following that, of course, those with neurological deficits as well. Now, how do they do? Traditionally, the rigid cervical collar is being used. However, in children, it's going to be very difficult to size a C-collar properly. It's often ill-fitting, and this can also lead to agitation and pain in a child, leading to uncooperativeness during the spinal motion restrictions. And this can be potentially dangerous to the child. What do I mean by that? So how do we do it? We can actually choose to just perform manual inline stabilization. This can be done in a neutral or a comfortable position for the child. However, a lot of times the personnel is going to be stuck there holding onto the child's head. So at times we will need to still use some form of restrictions using head blocks. You can modify it just like in this picture here and securing it with tape. Of course, if you have a luxury of having a good budget, then you can actually have commercial head blocks being bought for this kind of purposes. So other things that you use for spinal motion restrictions is the spinal board. And if you just use an adult spinal board, you can actually lead to a bit more problems. First is that you can actually have atlanto-occipital distractions from your C-collar. On top of it, if you use an adult spinal board, you can actually cause affection of the cervical spine. This will lead to worsening of the neurological injury. So if you look at this diagram here, diagram A is actually just showing a child on a normal adult spinal board where you can actually have a lot of flexion of the spine. And if you have B, which is a indentation or depression at where the occiput can actually be at a lower level compared to the body, then you would actually have a better spinal positioning. So if you can't afford it, you can actually have this kind of a two-in-one spinal board where the yellow area is actually where the pediatric spinal board is, and you have depression based on the different age groups or weight and height, so that they can actually have a better alignment of the C spine. If you don't have that, then just like the diagram C, you can actually elevate the torso by putting a 1-inch padding using either towels, blankets, just to make sure that you can align the spine properly. So here I just want to, just before I actually suffocate you all about pediatrics, I just need to actually highlight here that the management of spinal cord injuries is still the same in terms of using the advanced trauma life support. It's no difference. The only difference is that you want to actually have special considerations when you manage this special group of children. Now, other things that I would like to actually highlight here is that you also want to prevent secondary injuries by preventing hypoperfusion to the spinal cord. Therefore, you need to treat and reverse the shock promptly. Let's go to imaging considerations in pediatric populations. So interpretation of imaging in the pediatric populations can be challenging, and I will talk a bit more. I'm going to touch more on Skiwara as well as the term Alara. Here is when you are interpreting the imaging, you can actually have quite a number of pitfalls. And in children, you can see that sometimes you can actually think that there could be a subluxation at the C2, C3. This is a normal variant in a child, which is coined as pseudo-subluxation. So it's actually normal. You can see there from this diagram that the lines are actually, the alignments are out, but this is actually a typically normal variant of a child. Next is anterior wedging. So you can see here that the anterior part of the vertebrae is actually like a beak shape or wedge shape. You may actually misinterpret it as a compression fracture of the C-spine, but this is actually a normal variant. And because of spinal motion restrictions by the C-collar and the spinal board, sometimes you can appear that the intervertebral disc is actually more spaced in there. Therefore, you think that that could be a spinal cord injury. So be aware about that. Next is Skiwara. What does that stand for? Skiwara is a spinal cord injury without radiographic abnormalities. So what does this mean? This means that from your imaging, be it a plain radiograph or even your CT of the C-spine, it can appear normal, as in there's no bony injuries. However, there is a spinal cord injury, which is because of the laxity of the muscles and ligaments that I have mentioned earlier on. This is where the spinal cord is stretched, and then it actually goes back to the normal position, so you can't actually see the injuries on your usual standard imagings. So this is so what I want to actually share is another fun fact. In the neonatal spine, it is capable of being stretched for about 2 inches without getting injured. So when you have babies coming out from the birth canal, you can actually distract the neck, and there is no spinal cord injury. However, having said that, we come to the next imaging consideration is that when we do imaging, especially from the radiologist's point of view and especially from the pediatrics point of view, we want to actually use this principle, which is as low as reasonably achieved, meaning that we want to use as lowest dose of radiation so that we do not cause problems. And what problems from radiation is that we fear of the lifetime malignancy risk just by doing a head and neck imaging. So just like any head CT, even a neck CT can actually have a risk of radiation, so they can have a lifetime malignancy risk. So here in this paper, it just shows that, just talking about a C-spine scan, we're not talking about the head CT scan here. Every 40,000 CTs of the neck, you can actually have contributed to one patient getting a malignancy of the brain. It may sound like a very small, minute incident to a lot of clinicians, but if you put yourself in the shoes of the patient and the family, this is where it is devastating. If you're especially if your patient has no injuries. So what about, there's another paper that shows that if you do CT of the neck, you actually also can lead to a thyroid cancer. Thyroid is actually an organ that's very radiosensitive, so just bear in mind of what we actually do. And in this paper, it also shows that there is no increase in efficiency of management if you use a CT compared to a conventional plain radiograph. So with that in mind, whenever you think about doing a CT of the cervical spine, you need to actually think about this consideration. So what next? Now I'm giving you the fear of ordering a CT scan. So I always say that you have to balance the risk and benefits of doing any intervention. So you do not want to risk missing a C-spine injury, but at the same time you have to balance, are you actually contributing to a possibility of this child getting a cancer? So, well, we do have other modalities that we don't actually induce or give radiation, which is the MRI. However, with MRI, it's not widely available, at least in Malaysia. I'm not sure in the Philippines. But the time that the patient needs to be in the radiology department out of the ED or wherever the patient needs to be in is a consideration that we have to have. Not all children will be cooperative to be in a CT scan for at least for half an hour, 45 minutes, or even an hour. So you need to use sedation, and you must talk about sedation's risk of complications. And this could be a child that's actually very unstable, that requires critical care management that needs to be prioritized from going into a MRI suite. So there are many clinical decision rules, and it's very complex at times to know which is the best clinical decision tools to let you choose what kind of, which type of patients that you need imaging and what type of imaging. So there's the, for the C-spine point of view, you have the Nexus C-spine criteria. There's also a PCAN criteria. There's Canadian C-spine. There's the NICE guidelines. There's the Royal College of Radiology's trauma protocol. There's also the Royal Children's Hospital of Melbourne has also their protocol. So what do you do? You know, are you a risk taker and say that, hey, why not we don't even do a imaging? Or are you somebody who is risk averse? So who should get imaging? What type of imaging? Can we do selective versus whole body imaging, just like how you do it for the adults? So here I would like to just go through a few of the clinical decision tools. Nexus is one of the more common ones that everyone is familiar with. It is very good for your adult, your population, and it is also applicable for children, especially for those who are more than a year old. So for children, the only problem is that the sample size from the study is very, very small. And out of the study, those that is in the sample size for children less than 8 years old is only 1.3% out of the whole sample size for the studies. It performs very, very well for children who's 9 to 17 years old, but for the younger age group, it's yet to be seen whether it's actually very, very effective to pick up. So I'm not just going to go through the nexus. You know that they have this mnemonic NSAID. You can also still use it for the children should you decide to use this as a criteria for selecting your patients. What about Canadian C-spine rules? So for children that's less than 16 years old, this is not a clinical decision tool to be used, because in their population studied, it's actually all above 16 years old. So it's not helpful for us. What about Pecan? Pecan was actually created more than 10 years ago. It actually is very, very sensitive in picking up about 98% of the C-spine injury. It even advocates using plain radiograph against CT as a choice of imaging to rule this cervical spine injury however, it's not really validated yet. NICE came out with their own guidelines as well, and I find that it's very, very complex. For me, I like something simple, and I feel that this is too complex for me. If you want, you can still use it. At the same year, there's the Royal College of Radiology in UK who came up with their pediatric trauma protocol, and they used 7 criteria to choose imaging. So it's all about altered mental status of GCS that can point to a at least 13 and below. If the patient's intubated, if there is a criteria that is met that there's a C-spine injury needs to be ruled out, if there are other body areas that needs to be scanned, if there's any focal neurological deficit, if especially like paresthesia of the upper or lower limb, and if their plain radiographs can't actually rule out the injury. So there's a paper in 2020 that looks at all the C-spine injuries. Is there any change in guidance? And here, based on their database, they actually found that by using a clinical decision tool, you can actually decrease the rate of use of CT scans in C-spines. However, this is not statistically significant. And this is, again, I like to highlight because a lot of clinicians do use the CT scan to rule out a C-spine injury. Here, you can see there are over about 20% who are falsely negative, but the injury is subsequently picked up only on an MRI. So this is where you have to be a bit cautious using any of the plain radiographs as well as CT scans to rule out a C-spine injury. Again, this is back to Skiwara. So here, I'd like to actually introduce to you that the RCH in Melbourne has a very nice flowchart on how to manage based on their own protocols. However, it's not validated yet. I like it because they actually start to have the selective imaging. So I won't go through this in interest of time, but you can always Google RCH C-spine injuries. It's free online and it's available for everyone. So here, I like it that they actually select patients who they feel can have possible C-spine injuries, and they do use plain radiographs as their first line. And if there is something that is concerning, then or if it's something major from the word-go, then they would actually advocate MRI or CT scans. So the conclusion that I can get from the multiple clinical decision tools is that I think, first of all, as a clinicians, we need to actually determine whether there is any risk of C-spine injury in that particular child. So the mechanism of injuries and the past medical history is important, because there are certain groups of children that has potentially unstable C-spine that can lead to a C-spine injury. And the prerequisites before you use any of these clinical decision tools, you must look at their mental status, whether there's affected by any substance abuse, whether you have actually needs to give any sedations or analgesias that can alter the mental status of the child. Is there any distracting injuries? And then you must be able to do a proper and full examination of the C-spine. And this involves you must have an awake and a cooperative child. You must do a proper C-spine assessment and a full neurological assessment. So what about imaging? I think as general emergency physicians, you tend to actually think about things like PAN scan. For me as a pediatrician, I always think about using the ALARA because in my back of my mind I think about the radiation risk. So of course we want to choose the low risk or no risk point of care. MRI would be best, but I don't think any one of us have the luxury of imaging using MRI all the time. So if we can, some of the children, we can actually clear the C-spine clinically. If I can't, my first line to go to is probably an X-plane radiographs of the 3 views. And if these patients are actually high-risk mechanisms, then I have to choose between a CT versus an MRI, whether I need to do it immediately, the imaging, versus a delayed. I can actually send up to the ward, wait for a stabilization before we do it. And whether you need to actually scan the whole CT or you can do a limited CT, since that upper cervical C-spine is more commonly injured in the younger child. So there are limited evidence, and I'm sorry that I can't, share with you a very clear-cut guidelines right now, just because the incidence of C-spine injury is very, very small in children. I feel that we definitely need to develop a very good evidence-based guidelines if we want. However, it will take a lot of time because of small sample size unless we have a good collaboration. Here, I'd like to actually share with you, I'm in the midst of a work to plan a C-spine imaging pathway with one of the fellows. A good shout out to Laila Jan. She's one of the PEM fellows, so we are going to be doing that. We have actually had a good discussion with our radiology colleagues. They are all pediatric radiology consultants, and we have actually drawn up a pathway for selecting which is the best imaging while minimizing the possibility of missing any injuries. So watch the space, okay? So I'll just go back to this patient. This patient is a child who had fell from height, and because we have intubated, because of the high-risk mechanism, the patient actually did indeed go for a C-spine imaging, which is because he had a head injury, so it was also a head and C-spine imaging. And fortunately enough, there was no bony injuries, and after 48 hours of cerebral protection, the child was weaned off, and they could do a proper assessment, and this child was cleared of any C-spine injuries. Okay, so I'll end with my take-home message. I feel that as a pediatrician, I always have to talk about primary prevention. So injury prevention is the key. I think both in Malaysia and in Philippines, we need to talk more about safety and prevention before it happens. Well, in the meanwhile, if it happened, we need to balance keeping the child safe by preventing or minimizing the sequelae of trauma by doing a good secondary prevention, but at the same time minimizing the radiation risk. With that, I thank you.
Thank you so much, Dr. Yap, for your very comprehensive discussion of the diagnostic considerations in the management of pediatric cervical spine injury and walking us through all these clinical decision tools. Please reserve your questions for Dr. Yap We will have a panel Q&A with the second speaker after she has finished her presentation. Thank you so much, Dr. Yap.
Thank you.
We'll be with you in a while.
All right.
And now I will call on our second speaker. And the topic for this session will be geriatric trauma updates, and clinical management. And this will be presented to us by Dr. Halima Omar Muhammad Roman Cup. And she has finished her residency training in surgery at the Cotabato Regional Medical Center and fellowship training in trauma surgery at the UP Philippine General Hospital. She currently holds a position as chair of the Department of Surgery at the Cotabato Regional Medical Center. And she's also a faculty of Advanced Trauma Life Support here in the Philippines and a member of the Committee on Trauma, Philippine College of Surgeons. Let us all welcome Dr. Halima Muhammad Romanka. Dr. Halima, the floor is yours. You may share screen. Dr. Halima, would you like me to share your screen? Oh, she's here already. Thank you.
Yes, good morning, everyone. Assalamu alaikum. I'm sharing my slides. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Good day, everyone. I am Dr. Halima Muhammad Romankap, and I will be talking about geriatric trauma, updates in clinical management. There is no exact definition of geriatrics. It may start from the age of 65 years old and up, but this is not definite. There is such thing as the aging process, representing the biological changes that occur with chronological age unaffected by disease. There is also such thing as the process of aging, which is strongly influenced by the effects of the environmental, lifestyle, and disease states. In an institutional-based study, 20% of trauma are distributed among age 50 to 79 years old, mostly men, and less than 5% are 80 and above. Both local and international studies prove that the most common causes of trauma are fall, followed by vehicular crash, and penetrating injuries and burns. Due to the declining cellular functions and decrease in physiologic reserve, these patients have higher morbidity and mortality rate. Basically, the approach in the management of geriatric trauma will not change. The ATLS principle still applies following the ABCDEs of resuscitation. Blunted responses to hypoxia, hypercarbia, and acidosis can delay clinical signs of distress in older adult trauma patients. Serious injuries are likely to be present even when concerning clinical findings are not apparent initially. Diminished respiratory reserve often prevents patients from compensating adequately for chest injuries. Early aggressive airway management may be necessary and may include tracheal intubation or non-invasive positive pressure ventilation. Normal vital signs in geriatric trauma patients may be substantially different from their younger counterparts. Recognizing early shock is more difficult. Baseline hypertension is common and can cause relative hypotension to be misinterpreted as a blood pressure in the normal range. The effects of medications such as beta blocker can obscure the meaning of vital sign measurements. Trends of vital signs are often most useful than any individual measurement. Aggressive resuscitation is appropriate for the initial treatment of older adult trauma patients with hypotension or signs of hypoperfusion. One reasonable approach is to rapidly infuse a bolus of 500 ml, assess the patient's response, and repeat the bolus if needed. However, pre-existing conditions such as ischemic heart disease, heart failure, or renal dysfunction can cause older adults to decompensate from excessive fluid administration or blood loss. Therefore, it is reasonable to begin transfusing packed RBC if hypotension or signs of hypoperfusion persist after just 1 or 2 liters of crystalloids are infused. We should also check for the disability as well as the environment and exposure of the patient. Geriatric trauma patients are chronically under-triaged, increasing their risk for morbidity and death. We suggest that trauma patients over the age of 70 be evaluated at a nearest trauma center with a trauma team activation whenever possible, regardless of the mechanism. In addition, studies have suggested that any patient 65 years old or older with a systolic blood pressure of less than 110 be transported directly to a trauma center for evaluation and that a heart rate of 90 be used as the threshold for tachycardia in patients of this age group. In addition to the standard trauma history, the following questions are important to address with geriatric trauma. What happened immediately before the trauma? Example, is there an altered consciousness, difficulty in breathing, or change in vision? What medication is patient taking? Anticoagulant, antiplatelet, beta blocker, calcium channel blocker. What underlying illnesses does the patient have? Does he have hypertension, cardiovascular or renal disease, or diabetes? What was the patient's baseline level of motor and cognitive function prior to the traumatic event? And finally, does the patient have a written advance directive or a healthcare proxy that may be useful for determining the goals of care? As older trauma patients may not manifest obvious signs of injury, close monitoring is essential. Monitoring should include serial examination, including vital signs, mental status, and reassessment of any areas of concern. In addition to a cardiac monitor and pulse oximeter, we suggest using an end-tidal carbon dioxide monitor for any older patient with the potential for respiratory problems. Obtain basic laboratory studies in older adult trauma patients with known or at significant risk of major injuries. These studies are very important, especially the lactate concentrations and base deficit measurements. These are helpful in the management of these patients with multiple injuries who are at increased risk of occult injury. After primary survey, a thorough systematic secondary survey is necessary for all older adult trauma patients. It is important that these injuries must be checked at all times. There might be head, cervical, major burns, clavicular or rib fractures, hip fracture, pelvic fracture, and so on. Always remember that a number of anatomic and physiologic changes accompany aging in geriatric patients. Therefore, they are at greater risk of injury and death and impair their capacity to respond to the stress of severe injury. The physiology of aging is very difficult. Therefore, care must be taken to optimize the recovery of each patient. At the end of the day, we want to send home this 93-year-old patient on her Lamborghini Aventador. With that, I'd like to say shukran, thank you, and terima kasih for listening.
Thank you so much, Dr. Romancap, for
Thank you
that
very much.
concise presentation on geriatric trauma. Now I would like to invite Dr. Yap and Dr. Romancap for our Q&A. So welcome back. We have a few questions in our chat box. And the first question I will throw to Dr. Yap. Having an agitated or fearful child, how do we promote cooperation and ease in pediatric patients who would undergo imaging studies, ma'am?
All right. So what I understand is talking about imaging and agitated child. So a lot of times we have to actually look at the child's development. If they are older children, we usually will just have to explain to them. Having their parents or a familiar guardian around would be the better option, so that they can actually calm down. And as long as you have actually explained to the older child, they should be able to calm down. Of course, pain management is very important. If they are still in pain and you don't manage them well, they will still continue to be uncooperative and agitated. Now, coming on to the younger children, of course, they would developmentally not be able to understand us explanation. So what we have to do is that we can use distractions. So things that they are familiar, their toys or things that the guardian brings along is going to be helpful. This is a time that we would probably allow them to have some screen time, watching some videos or singing. Sometimes our staff will be also doing singing. Bubbles, that kind of things. Of course, the other thing is that this imaging is really important. Then we will actually have to use sedation, such as using ketamine, any of your sedation protocols that you have locally. So those are the things that we would use. We would not use force or restraints, especially in an agitated child with a spinal cord injury, because it may actually worsen the injury. I hope it answers your question.
Yes, thank you so much. So we are not, if we can do more of the behavioral techniques, it's better than using chemical agents or sedatives.
Yeah,
Thank
correct.
you so much. And for Dr. Romancap, the question is, what are the common pitfalls committed by physicians in the emergency department that you have observed in your practice in managing geriatric patients, doctor?
Yes, as I have mentioned earlier, geriatric patients have this aging process and the process of aging as well. Now, both biological and the disease-free plus the disease state of the patient could contribute to the different presentation of the patient at the emergency room. Remember, an elderly patient, 65 years old and older, usually are into medications or are into different are having different disease entities that could contribute to the different levels
and differences in the vital signs, as well as the response to the different treatments given at the emergency room. I have mentioned earlier that there is this under-triaging of these cases. They think that the patient is normotensive, but in fact, the patient is hypertensive and losing too much blood. But the presentation at the emergency room, the vital signs will show you a normotensive 120/80 blood pressure. But in fact, the patient is already losing too much blood and his normal blood pressure is at 140/100. And he's only taking calcium blockers or beta blockers to maintain his blood pressure into normal. So these are some physiologic changes that could contribute to the mismanagement of these cases. There are also times when the patient are given too much fluid because they think that the old habit of giving 2 liters of isotonic warm solution is beneficial to these elderly patients. But in fact, the most helpful technique is permissive hypotension or limiting the fluid to be given. If the patient loses blood, same with other trauma patients, then we can give blood. Instead of giving too much fluid, the patient may go into congestion and other complications after treatment in primary survey. So in the triage area, we must also be aware not only of the mechanism of injury, the type of injury sustained, but also what are the possible medications, comorbidities that is present in our patient so that we will not under-triage these cases. So these are the common pitfalls, especially to those who are not well experienced with geriatric trauma kasi as I have mentioned, these are only 20% of the populations and most of these are fall and not from vehicular crash. So they rarely receive this patient at the emergency room. Thank you very much. Back to you.
Thank you so much. I think I fell into one of those pitfalls earlier in my training and that really helped me a lot to try to process this experience. Thank you, Dr. Romancap. There's another question for Dr. Yap. How practicable is EFAST in pediatric population?
Okay, thank you for the questions. Yeah, thank you for the question. I think it's probably not so much related to the topic that I just presented, but it's still on trauma. So yeah, EFAST has only a sensitivity of about 50% to pick up, the free fluids, especially in the intra-abdominal injuries in children. So if you're looking at that, then you said, like, why should we perform EFAST, right? It's like flipping a coin and getting a yes or no answer. So what I can say is that because when you talk about extended fast, it also includes the pleural cavity as well as the pericardial space for the free fluid. It still has the function that it's supposed to do, which is to look at those things. Of course, to increase the sensitivity, you need to include 1, clinical assessment of your patient, 2, to do a serial EFAST to increase the sensitivity, as well as 3, serial hemoglobin levels. This will actually increase the sensitivity of your EFAST in detecting a blunt trauma of the abdomen, as well as not just using this EFAST as a ruled out tool. You probably wanted to use it as a rule-in tool. So what I mean by rule-in is that if you do see free fluids at the spaces that you are supposed to look for, therefore there is an injury. If you do not see it, but clinically this patient is still in shock and you cannot explain by looking at other areas for bleeding, then you must assume that there is an intra-abdominal injury and manage accordingly. I hope that answered the question.
Yes, I think it was very clear. Thank you so much, Dr. Yap.
Thank
and another question for Dr. Romancap. How do we differentiate traumatic brain injury in elderly patients with dementia and Alzheimer's disease?
Yes, thank you. That was a very good question, actually. That is another pitfall at the emergency room when you receive these patients, actually. When these patients, if they are accompanied by watcher, take note, if they are accompanied by watcher, you can ask the family or the immediate watcher if they are with the patient all throughout. if the patient is experiencing dementia already or Alzheimer's disease. If not, always remember that anything that happens after the trauma can be contributed to the traumatic injury, probably the traumatic brain injury, rather than speculating, oh, maybe this patient has already dementia, that's why he cannot remember what exactly happened before he fell from the stairs. Or maybe the patient just cannot remember his family members because he already have Alzheimer's disease before the injury. It's not the case. If there is no watcher or there is no folks with the patient upon arrival at the emergency room, we must treat this patient as or manage them as part of the traumatic brain injury, or probably give them all those necessary medications as early as possible. And when the folks arrive, there is no harm to the patient if we have already started it. It will be beneficial if and when these patients are not experiencing Alzheimer's or dementia at all. So again, history taking is very important, but there is no such thing as good history taking in an emergency room crowded with too many patients, as well as nowadays we don't allow watchers to come into the emergency rooms without a negative RT-PCR because of the pandemic, especially in situations here in the Philippines. As well as here in our region in Cotabato City. So we must manage them as probable complications or outcome of the traumatic fall. Probably the patient hit the head, and we can finalize and diagnose it later with a definitive diagnosis after having a CT scan or an MRI. Then we can stop the medications that we have started at the emergency room, rather than assuming that the patient already has dementia because the patient is 93 years old or Alzheimer's disease, which is not correct. So always go into the safer side and manage it rather than assuming. It's better to manage it rather than assuming. So I hope I have given you the exact answer for that, but others may have a different point of view.
Okay. Thank you so much, Dr. Roman Cap and Dr. Yap, for your wonderful presentations. Allow me to present our certificate of appreciation to the both of you. So the certificate of appreciation is hereby awarded to Dr. Yap Xiaoling, who has contributed as an invited speaker to the Mascot Trauma Series held this 20th day of November 2021. Signed by Dr. Shah Jahan Mod Yusuf and Dr. Azlan Norzan. And the same certificate is awarded to Dr. Halima Muhammad Roman Cap, also signed by the same signatories. So thank you again for your sharing your time and expertise in this webinar.
Thank you very much. Thank you very much, Dr. Yap, Dr. Gerlan.
Thank you to both as well.
Now we will move for another break. So we will have a 5-minute break before we proceed to our panel discussion on medical legal considerations in trauma. Thank you.
Z-Medica develops, manufactures, and markets innovative hemostatic devices to support a broad range of applications and markets around the world. Our mission is to save lives and improve patient outcomes by offering a hemostatic solution that leads to faster bleeding control. QuickClot is a proprietary technology which consists of a non-woven material impregnated with kaolin. There are three main categories of methods to control bleeding: standard gauze and lap pads, active hemostatic agents, and passive hemostatic agents. QuickClot products provide hemostasis like a hemostatic agent with the placement ease of a standard gauze or lap pad. The novel technology enables maximum absorption and promotes robust clot formation. Kaolin is the unique differentiator for all QuickClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuickClot products have a track record of success. Starting in the military as the hemostat of choice, QuickClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuickClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, applied directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second cat above and side by side to the first. Reassess. Route the band between the clips and over the rod. Secure rod and band with time strap. If able, record time of application on the time strap with the permanent marker included in the kit. Combat application tourniquet. CAT. Storing the CAT in the quick launch configuration. Take the band out of the buckle. Ensure the rod is not secured in the clip and all turns of the rod are removed. Stretch out the band twice, horizontally, like an archer, to straighten it out. Pass the red tip through the slit in the buckle. Pull 8 inches of the band through. Fold it back and adhere the band to itself. Flatten the loop band. Place the buckle in the middle of the flattened band. Fold the CAT in half, placing the buckle at one end. Secure the rod inside a clip to lock it in place. The CAT is now ready to be used for future training. These are some important points to remember. Never place a tourniquet over a joint, such as a knee or elbow. The tourniquet can be applied over clothing. If the site of the bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible, on the injured limb. Never use the tourniquet over items in your clothing. For larger limbed persons, 2 tourniquets may be used, but must be applied side by side, with the rods not interfering with each other. Once again, the band should be tight enough that the tips of 3 fingers cannot slide under the band.
Standing
we still have one panel discussion on medical legal trauma. Please stand by for that lecture.
Applications and markets around the world. Our mission is to save lives and improve patient outcomes by offering a hemostatic solution that leads to faster bleeding control. QuickClot is a proprietary technology which consists of a non-woven material impregnated with kaolin. There are three main categories of methods to control bleeding: standard gauze and lap pads, active hemostatic agents, and passive hemostatic agents. QuickClot products provide hemostasis like a hemostatic agent with the placement ease of a standard gauze or lap pad. The novel technology enables maximum absorption and promotes robust clot formation. Kaolin is the unique differentiator for all QuickClot products. Kaolin is an inorganic mineral that works on contact with blood and accelerates the body's natural clotting ability. The contact between negatively charged kaolin and blood activates factor 12 on the intrinsic pathway. This, in turn, accelerates the body's natural clotting cascade. Leading to robust clot formation and faster bleeding control. QuickClot products have a track record of success. Starting in the military as the hemostat of choice, QuickClot products have since expanded across a broad range of segments and bleeding scenarios. For faster time to hemostasis and significantly less blood loss, it's QuickClot or it's not.
Combat Application Tourniquet, or CAT. Two-handed application. In life-threatening situations, the items in this bleeding control kit are designed to provide you with simple yet essential medical equipment to stop severe bleeding. Empower anyone to assist in life-threatening situations. Now you can easily prepare yourself for the unexpected. Lives are depending on it. Gloves should be worn during the application. To begin, remove the CAT from the bleeding control kit. For best results, expose the skin where the wound is located. For this two-handed application, pull the band out of the CAT buckle. Route the band around the limb. Position the CAT 2 to 3 inches above the bleeding site, applied directly to the skin. Pass the red tip through the slit of the buckle. Pull the band tightly and fasten it back on itself all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and re-secure. Twist the rod until the bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second CAT above and side by side to the first. Reassess. Secure rod and band with time strap. Record time of application on the time strap with the permanent marker included in the kit. Assure the patient that help is on the way. Combat Application Tourniquet, CAT, one-handed application. Insert the injured limb through the loop in the band and position the CAT 2 to 3 inches above the bleeding site, directly to the skin. Pull the band tightly. Fasten it back onto itself, all the way around the limb, but not over the rod clips. The band should be tight enough that the tips of 3 fingers cannot slide between the band and the limb. If the tips of 3 fingers slide under the band, retighten and resecure. Twist the rod until bleeding has stopped. Secure the rod inside a clip to lock it in place. Check for bleeding and distal pulse. If bleeding is not controlled or distal pulse is present, consider additional tightening or applying a second cat above and side by side to the first. Reassess. Route the band between the clips and over the rod. Secure rod and band with time strap. If able, record time of application on the time strap with the permanent marker included in the kit. Combat application tourniquet. CAT. Storing the CAT in the quick launch configuration. Take the band out of the buckle. Ensure the rod is not secured in the clip and all turns of the rod are removed. Stretch out the band twice, horizontally, like an archer, to straighten it out. Pass the red tip through the slit in the buckle. Pull 8 inches of the band through. Fold it back and adhere the band to itself. Flatten the loop band. Place the buckle in the middle of the flattened band. Fold the CAT in half, placing the buckle at one end. Secure the rod inside a clip to lock it in place. The CAT is now ready to be used for future training. These are some important points to remember. Never place a tourniquet over a joint, such as a knee or elbow. The tourniquet can be applied over clothing. If the site of the bleeding is not readily apparent, place the tourniquet high and tight, as proximal as possible, on the injured limb. Never use the tourniquet over items in your clothing. For larger limbed persons, 2 tourniquets may be used, but must be applied side by side, with the rods not interfering with each other. Once again, the band should be tight enough that the tips of 3 fingers cannot slide under the band.
So welcome back, everyone. And now we are ready for our panel discussion on medical legal issues and trauma. And with us this morning are our 2 panelists, Dr. Mahatar Abdwahab and Dr. Joel Macalino. May I now call on my co-moderator for this session, Dr. Hafizah Zainal Abidin, who is a senior emergency physician at a senior lecturer at the Islamic Science University of Malaysia. She completed her second master's degree in medical ethics and jurisprudence from UITM and have a deep interest in managing medical complicated cases from the perspective of ethics and medical legal view. She recently passed her diploma of legal medicine exam, and she is keen to explore in medical ethics and medical legal research relating to emergency medicine. Let me just fix my screen share for a while. Hello, Dr. Hafiza. Allow me first to introduce our first panel speaker, Dr. Attorney Joel Macalino. Dr. Macalino has finished his residency training in surgery at the UP Philippine General Hospital and his fellowship training in trauma surgery also from the same institution. He is a fellow in surgery and critical care from the Oregon Health Science University and finished his Bachelor of Law from San Beda College of Law. Presently, he is a clinical associate professor at the UP College of Medicine, chairman of the Department of Surgery at Tondo Medical Center, professor at San Beda College of Medicine and College of Law. He is also the Philippine representative to the ASEAN Collaboration for Trauma and is a chair of the technical working group for the creation of trauma center at the Department of Health. Our second panelist is Dr. Mahatar Abdul Wahab, a senior consultant emergency physician and head of emergency and trauma services at the Malaysian Ministry of Health. He is head of the Department of Emergency and Trauma at Hospital Kuala Lumpur, and he had vast experience in handling medical legal cases and issues in Malaysia, often being called in subject matter expert and also consulted by his peers at work. He is actively involved in the training and is a consultant speaker in medical legal courses in Malaysia, conducted by the Academy of Medicine in Malaysia under the College of Emergency Physicians. So first, may I call on Dr. Attorney Joel Macalino for his brief presentation on the differences in medical legal practice in the Philippines and Malaysia. Dr. Macalino, the virtual floor is yours, sir.
Thank you, Madam Moderator. I put together a short piece lecture on the differences in medical legal practice in the Philippines as compared with Malaysia. Well, the primary source of my knowledge was reading this piece on a review of medical malpractice in Malaysia that came out in 2014, I think. So it claims that the basis of malpractice claims in Malaysia is the tort law. Tort law is an area of law that covers mostly civil suits. And if we're talking about tort law, there is an award for damages. While in the Philippines, the basis for the malpractice claims are, again, we have a tort provision, that's Article 19, 20, and 21 in the Philippines. And that is the chapter on human relations. Let me just show that it really would have, if you win this case or the patient wins this case, they shall be indemnified or shall be compensated. But then that's not the whole basis of malpractice claims. There are actually three: criminal laws, civil laws, administrative, and even administrative laws. The patient would usually start with the criminal law. So that criminal law is Article 365 of the Revised Penal Code. And then they would bring you to the administrative aspect, meaning the Professional Regulation Commission, whose job is only up to revocation of your license to practice. Now, on civil laws, there is also another provision on quasi-delict, which again, the winning party would be obliged to pay the damages done. Again, first they bring you to the criminal court because you don't have to pay the docket fee. As for administrative law, you only pay 500 pesos. And As regards the civil loss, it's about 1 or 17,000 pesos per million claimed. This is again the characteristics of the Malaysian system. They say that the system is slow, consuming about 4 years, inefficient, and unrealistically difficult. That is for Malaysia. And I'd like to highlight that the 4 years they are saying is that of an average. That is from the event up to the start of litigation. Now, because there is in Malaysia, I think there is a Limitation Act of 1953, which is equated. In the Philippines, it's called prescription period. In Malaysia, claims cannot be brought after 6 years from the date on which the cause of action occurred. Now, let's see what about the Philippines. The Philippines, as regards the criminal laws, the prescription period is about 10 years. If it is civil laws, it's 5 years. So typically, medical malpractice claims in the Philippines are prosecuted within 5 to 10 years after the event. Regarding access to health records, the Malaysian Medical Council actually said that the patient's medical record is the property of the medical practitioner and the healthcare facility. Well, here in our country, in the Philippines, the medical records is actually more of the patient rather than the practitioner or the hospital. Probably the records there in the data in the medical records is that of the patients, and probably the paper in which it is written is that of the hospital or probably the practitioner. And we have this under the Data Privacy Act coming from the PhilHealth. In medical legal cases, information may be disclosed to the authorized personnel upon authorization of the patient. So that is a proof that the medical legal records or medical records is that of the patient, because he has or she has to authorize opening of his or her medical records. On the expert witness that is needed to show that there is damage, in Malaysia, there is what they call, quote and unquote, conspirators of silence, meaning the doctors wouldn't want to witness against co-doctors. In the Philippines, again, we need the reasonable opinion of another doctor, and generalize the doctors, the other doctors, usually there is generalized reluctance to witness for and against a co-doctor. This is the rising medical malpractice claims in Malaysia. From 2006 to about 5 years later, there's an increase of 500%. This is the conclusion. What is needed is a system that ensures greater accountability, delivers fair compensation to victims, reduce costs, and lengthy litigation. That's also our wish for the Philippines. Thank you very much.
Thank you so much, Dr. Macalino, for giving us that overview of how different the systems are. For this next panel, we will like to invite Dr. Mahatar to the panel, and I will turn over the moderatorship to Dr. Hafiza for the presentation of the cases. And since this is a panel discussion, we will have the opinions of our panelists. Dr. Hafiza, thank you.
Thank you very much, Dr. Faith. Thank you for having me here today. So I will share my screen now. Okay, Assalamualaikum and good morning still. I would be moderating this session with Dr. Faith, and we have our esteemed panel today, Dr. Mahada and Dr. Macalino. So in this session, I will be presenting cases, 4, if we have time to go all through 4 cases. and then discussion in between that cases of the cases issues. And then later on, we will have some time, I hope, for the Q&A questions from anyone else. Okay, so a bit of disclaimer. So the cases are mainly fictional. The similarities present are only intended for the purpose of discussion and learning. So we will go to the first case. Okay, the first case is 34-year-old Malay man was brought by a passerby to emergency department of a tertiary hospital after being involved in motor vehicle accident. So patient complains of chest pain and shortness of breath. The vital signs are normal except patient was likely hypoxic, however improved with supplemental oxygen. The primary survey revealed no significant life-threatening injury. However, the chest X-ray shows multiple rib fracture with right pneumothorax. So the medical officer counseled the patient for a chest tube, which was indicated for the patient. So he or she explained that the patient's the condition at that time, the risk, the benefit of the chest tube, and the patient agreed. So the patient signed a consent form. After that, the chest tube was done by a house officer, so a trainee doctor, under supervision of the MO. So as we know, in most of tertiary hospital, we have housemen working in our department. However, halfway through, as commonly happen, we don't only have one MO in each zone. So the MO was called to attend to another case. So another MOC continued supervising the HO. And the chest tube of 28 French was inserted and noted there was blood coming from the chest tube. So patient after that become a complaint of abdominal pain, become tachycardic, and fast scan showed free fluid. Thus, he was resuscitated, referred to the surgical team, and intra-op finding revealed iatrogenic liver injury secondary to the chest tube insertion. So we come to the first discussion. So I would like to invite both our panels, Dr. Makalino and Dr. Mahada. So in this case, I think what we can discuss is who can or should take the consent in this case, and maybe the differences if there is from each country, and was the houseman responsible in performing her duty, and what was the liability of the medical officers, both medical officers. So maybe we go to the number 1 and number 2 first before we go to the number 3 discussion. So I would like to invite our panel, Dr. Makalino or Dr. Mahada. You want to comment first?
Dr. Makalino, you want to start the ball rolling? You want me to start the ball rolling?
You can start, Dr.
First and foremost, thank you very much for inviting me to be part of the panel. Thank you very much, Hafiza, for presenting that particular case. I think one of the gist of the first questions actually that we need to look into actually the issues of either consent is necessary or not for these particular patients. I think that's one of the first questions need to be asked first before we go into the issues who can take and should take the consent. So that was very clear in the event that is considered as life-threatening or life-saving intervention under the principles of necessity. It doesn't matter if you look into Commonwealth law, it's very clear that under the principles of necessity, the paternalistic views, meaning that the doctors will do the best they can in order to make sure the best outcome for the patients ethically. So, and therefore, under that circumstances, actually consent becomes secondary. So intervention must be carried out. But as you highlighted in this particular case, actually there are a form of stability in the patients, and therefore consent was taken in order for them to carry out the chest tube insertions. So what are the contentious issues? Who can and should take? It's not who. The important question to ask actually, either the person that able to seek for consent from the patient actually can provide the sufficient information with regards to the procedure. I think the key word here actually is sufficient information that need to be given to the patients with regards to the procedure or any forms of intervention need to be carried out. I think this is pretty clear. So it can be a house officer, it can be a medical officer. Best actually is the surgeon to take the consent. But importantly, if the house officer or medical officer able to provide the necessary sufficient information and the risks, the benefits of that particular intervention to that particular patient, and therefore the issues of who can and cannot take the consent should not arise. So and therefore, so if the chain of hierarchy that in any situation whereby if the medical officer such is credentialed and privileged to conduct such procedure, we are of the assumption that he or she can provide the necessary sufficient information to the patient. So based on that assumption, and therefore it should be the medical officer, at least in terms of ranks of seniority and competency, that should able to take the consent for this particular patient if there is a need to do so. So remember that second question, if there is a need to do so. If there is some form of hemodynamic instability, that consent should not be taken in any way because life-saving intervention should come first. So that's my first point with regards to this. I would love my colleague to comment on that as well. Dr. Macalino, I pass it to you.
Dr. Matar, I'm tempted to say I agree. But then in the Philippines, yes, there is an emergency rule wherein if the patient is really suffering and it's a life or death situation, then the consent may be postponed to some other time wherein the patient is better already. But then my practical advice is whenever you can take the consent, do so. And then the person performing the procedure will be the one to take the consent. That's just here in the Philippines because a relatively benign procedure just like a chest tube insertion may end up like this first patient of ours. Thank you.
Thank you, Dr. Mahada and Dr. Macalino. So the third question is, whenever an injury iatrogenic in nature, so what do you think that our steps should be in improving or avoiding the injury to happen in under our care? Do you have any advice or any advice legally, ethically of how we should manage this? Dr. Macalino?
Well, we teach our residents to be safe when inserting the chest tube. So generally, it's the fifth ICS anterior to the mid-axillary line. In that area, you are relatively safe unless you monkey around with your procedure. So some senior residents would insert it, since we will be draining blood, would insert it at the lowest portion, probably 7th ICS. But then we always call their attention, and for safety purposes, we say that it is the 5th ICS anterior to the mid-axillary line. Thank you.
Dr. Mahada, any tips?
For me, apart from training and levels of competencies of the various doctors that are able to perform it, I think at the levels of the hospital, this is where actually the credentialing and privileging process must take place. So that actually will relate to the competencies of the doctors actually conducting the procedure. If that process is being fulfilled and then the doctor is competent to conduct such a procedure, yes, things can go wrong, right? Things can go wrong. But if you follow the appropriate practice of conducting such procedure and then knowing that such risk can occur, so yes, that's what we call consequences that sometimes at times that still can occur, although that you provide the necessary safety net in order to prevent such event or consequences, untoward consequences. Meaning that bottom line, at the levels of the hospital, at the levels of the institution, there's be very clear guideline in terms of levels of competency and the process of credentialing and privileging for those people that can conduct such procedure. So that's my comment on it.
Okay, thank you, Dr. Mahada. So we go on to the second case, but if anyone wants to add in any question, just feel free to type in. We will address it during the question and answer session later. So the second case is from Dr. Faith. A 23 years old female suffered from traumatic brain injury. At the emergency department, she was already GCS3. The resident on duty was able to convince her parents to donate her organs. However, the patient turned out to be pregnant at 24 weeks period of gestation, but not married to her boyfriend. So for our second discussion, the first question is, should the mother's life be sustained long enough to deliver fetus to a viable age? So maybe we will start with Dr. Macalino. What do you think should be done? Should we sustain the life of the mother?
I think so. Every day that would pass after this event would increase the chances of the fetus to be delivered successfully. There is what we call the age of viability, which is about 24, 25 days. If we can sustain the life of the mother for 1 to 3 days or even a week, then so much that would be better for the fetus. But then there is a there is a problem as regards to medical death and legal death in the Philippines. Now, legal death is skewed towards organ donation, and medical death is what we know as doctors. So, I guess since the Organ Donation Act is almost or is the same for most countries, I guess what they are implementing now is the legal death to be able to harvest the useful organs of the patient. But then this patient is not yet medically dead. So my answer to number one, yes, sustain the mother's life um, for a few days. Every day would be a big difference in the viability of the fetus. Thank you.
Thank you. Dr. Mahata, how about Malaysia? Should we sustain the mother's life for the fetus?
In principle, I do concur what has been mentioned by my esteemed colleague actually, because the principles is the same, right? I think what are the principles that we need to address in this particular case? So the principle that we need to address actually, what is what I call the best outcome for the mother. So I think that's the first principle, because remember, there's one component about human rights. There's human rights, what we call privilege, does not arise until you are born, right? So meaning the fetus actually don't have that human rights, right? So, but at the same time, we recognize there are two lives needs to be managed accordingly. So when what two lives need to be managed accordingly, the priority is always the mother's life first, to sustain the mother's life, and then look at into the feasibility of what I call managing the fetus or the unborn baby. So in this particular practice, actually, if actually in the case whereby there is a brain death or a situation in such as this, actually what the practice are, first actually it must involve multidisciplinary input from the various stakeholders in managing such cases. I think that's pretty clear. But the principle guided by this, actually we look at the fetal viability. There is very clearly the chances of survival of the fetus going to increase dramatically after 24 weeks. Even 28 weeks is even better, after 32 weeks is even better. I think if you look at the case report, if I'm not mistaken, there was a paper that was published in 2010, actually looking at the various case report all over the world. The principle is the same. The principle is the same, meaning that they look at the issues of the mothers, and then only then they look at the issues of the fetus. But if there is evidence to suggest there is a viability of the fetus can be delivered in a way survive, and not just survive, but less handicapped due to that, and then the decision being made to prolong the mother's life as long as possible to make sure the baby is born, survive, and have a minimal chances of handicap. I think these are the overriding principles need to be addressed in the question number one. So I just go straight to the question number two. who has the right to decide the interests of the unborn child? I did mention this briefly in my first comment. I said, is the parents. So in this particular case, the mother is incompetent to make a decision. So, and therefore, who are the next of kin or the by legal or law of the country, who are the next people that is able to provide the necessary consent for such procedure to be carried out. So I think each country is different. So in Malaysia, we use the words of next of kin. There is a list of hierarchy who can actually provide the necessary consent. Since that this patient, they are unmarried, so by legality, the boyfriend do not have a legal rights to the unborn child. So it should be the parents of this particular patient who actually more or less have the legal right, or their siblings. So that's my comment on it.
Agree with the comment. Even in the Philippines, the hierarchy of relatives, meaning usually the first degree relatives would be the son, the daughter, and then it goes up father or mother, and then it goes lateral to brothers and sisters. The law does not take into consideration here the father unless they are really married.
Okay, thank you. We go on to case 3. Okay, case 3 is a 44 years old Malay lady with hypertension, diabetes, and dyslipidemia. She was involved in motor vehicle accident and was brought by ambulance to a tertiary hospital. So primary survey showed that the patient's right limb deformity, and X-ray revealed there is a closed right femur fracture and open right tibia fibula fracture. And patient was in severe pain. After prolonged 10 hours in emergency department, she was admitted to the ward. After about 1 month of hospital stay, patient developed complication of the right lower limb, which led to above knee amputation. So the patient complained to the doctor in ward about the prolonged hospital stay, and the subsequent complication that she suffered was due to the delay in treatment she received since she was in emergency department. So for the third discussion, maybe we would like to explore into how the immediate steps of damage control, if we are the doctor or staff that the patient complains to regarding the possible negligence that happened. And about the negligence, how do we differentiate a complication from an injury? Or is it a delay or mismanagement from the injury that the patient suffered? So maybe Dr. Mahada wants to go first.
Thank you, Afiza. Okay, the first question, what are the gist of the issues arises? Is the issues of managing complaints, all right? So if you look the way that's in practice, why that complaint arises? So complaint arises from many factors. But if you look at the top 3, why that complaints arises, is the first one is communication, the second one is communication, the third one is communications. So that's why complaint arises. So when the complaint arises, then it will lead to issues of possible saying that we're saying that probably the doctor tried to hide something from the family members or from the patients. So when that happens, there will lots of pessimism, there are lots of negativities, and whatever you do in order for them to explain to them later on, it's going to have a bit of untoward consequences to that particular patient or to that particular case. So how then we go about for that? First and foremost, of course, there is actually we look into managing complaints. That's why we keep saying many times actually, when there is a trigger where actually a complaint arises, complaint must be managed accordingly. Just looking at like any other organization where we receive feedbacks from the care, that service that we provide. And therefore, there must be what we call a very clear organization that provide such a platform for the complaints to be managed. And how it should be managed, this is where actually the interaction between that particular organization with the complainants comes along. when this happen, this is a very important aspect that we need to realize actually when the interaction occur, the concept of transparency, the concept of honesty, that to tell them what exactly happened. Usually by doing that, there will be some satisfactions towards the event or the incident that's already occurred. I think that's to start off. So either there's a possible negligence or not later on, that's another possibility that we are going to look into. But remember, in order for us to say a particular case have issues of negligence, the burdens of proof is only based on the plaintiff. So meaning that who actually made that particular complaint. We know that that's the law in Malaysia, even in Commonwealth countries. So in order to do that, so the plaintiff must prove there is an issues of the doctors in providing the necessary duty of care to that particular patient. And the plaintiff also must prove there is a breach of duties to that particular doctors in order to provide the necessary care, either by omission or provision of care they carry out during the intervention. And thirdly, after this breach of duty, either by omission or provisions of care, there is a related consequences of damages that occur due to that. You can fulfill all that, then probably you can talk there is an element of negligence that leading to this particular case. So, but before we go into that, actually the components of managing the complaint, the components of communication and providing necessary platform for the interaction to be carried out between the organization and the complainant is the utmost important actually to damage control or to minimize the unnecessary consequences after that. So that's my comment on that.
Okay, Dr. Marcelino, your comments?
Well, as for me, if a similar thing happened in the hospitals in which I work with, they call the medical director, and the medical director calls me. My initial step is to schedule a meeting, secure the records, and look for or a photocopy of those records to see what happened really as regards to this patient. And this is what we call the damage control. In the damage control of this patient, no, we we usually would or there will be only one doctor to talk to the patient such that there are no other information that the patient will get aside from the official explanation of the doctor talking to him or her. Patient complaints regarding possible negligence. Well, that is the right of the patient. If she thinks that there is possible negligence, then it's her right to seek consult with the legal or medical legal officers, but not that hospital. But then it's not yet a given whether the complication was that of an injury or a delay in the management of this injury. So that we have to determine. If by my assessment and the assessment of the medical director, we did not give standard of care, then we talk to the patient, and then probably there's a term we use. That term is service recovery, wherein the payment, hospital bills of the patient, probably the professional fees of the doctor would be severely discounted. So it is the way that the medical legal officer would handle these cases. That's it. Thank you.
Thank you, Dr. Marcelino. So I guess it's a very complicated process. As we know that trauma also involves many departments. So as Dr. Mahada said, communication is not that easy. So we have inter-department communication, we have communication with the patients. So it's a very a lot of things that we can improve here.
If I may add on to this, the third case just now, actually, if you look based on the comment by Dr. Marcelino and myself, I think one of the take-home message from that particular case actually is the issues of clinical governance. I think that's the take home that we need, all of us have to realize actually when managing such complaint, because when a complaint arise, that will reflect the clinical governance of that particular institution in managing a particular case. So when the clinical governance is strong, that's where all the necessary steps being taken, either the medical directors or a team of that could conduct the root cause analysis and review objectively the notes, so on and so forth. I think that's the one that we need to highlight in those case number 3. Thank you.
Yes.
Thank you, Dr. Manda. Yes, I agree. Okay, so we go on to the fourth case. Okay, this case involved 15-year-old girl. She was brought by her school warden after sustaining a sports injury during a class activity. So upon further review, there is multiple bruises all over her body with evidence of multiple healed bone fractures. So there was evidence of abuse there. So, however, the child parents stay in another state and there is no family members nearby the school or the hospital. So the school warden volunteered to bring the patient back to her parents, since at that moment when the doctor attended, her parents are uncontactable. So for this case, we would discuss on how the doctor, the attending doctor at that time should act. Should they allow the patients to be left with the school warden? What do they do if the parents are uncontactable? So Dr. Makalino, maybe you would like to start?
If the parents here are contactable, there is such a thing in the Philippines that the term we use is substitute parental authority. If the patient is school age, the authorities in the school may act as parents or the primary consideration of the child. So for this patient, um, discovering that there are so many bruises, again, that is probably uh, some form of abuse, then the school authority has the right and the duty to report such a thing. In the Philippines, we also have the Women and Child Protection Desk. And the idea for that is that it will be present in almost all regions, but then that's not yet a reality nowadays. But then you can contact the Women and Child Protection Unit. It's situated in the PGH. There is a group of volunteers there consisting of pediatricians, probably OB, judges, and even lawyers and policemen, which could do or who could do the investigation, further investigation, and follow up in this case. So, what procedure of treatment should be done for the patient? Well, uh, again, if uncontactable, the parents are the substitute authority of the school authorities would play into this kind of situation. Can the wardens consent for this? Primarily, it's the school authorities, not the warden.
Okay,
Thank you.
Dr. Mada?
All right. In this particular case, actually, in Malaysia, actually, we have an act, which is the Child Act 2001, which is the provision in this particular act is very clear with regards to the care needed to the child. So, and first foremost, who actually a child in Malaysia, those individuals below the age of 18. So meaning that in this this particular case, whereby there is a possibility of non-accidental injury that occur, and with number one, number two, actually there is an issues who can provide the necessary consent for the child if intervention required to be carried out. So again, under the Child Act 2001 in Malaysia, there is a various sections that are available into this, but the principle behind it is very clear that the authority or the doctors that managing the case is always looking at the best interest of the child. So therefore, so if there is a need for the child to have to be admitted to the hospital for the purpose of treatment, and that can be carried out even without the consent from their parent. More so if their parent is not contactable. So because we have to remember, so though that there is a concept of parental consent, but parental consent is not an absolute, right? So meaning what? Meaning that there is a limitation based on the premise that the parental consent will be given based on the best interest of the child. If the parents actually were called act not to the best interest of the child, this is where actually the parental consent will not become valid. So these are the circumstances in Malaysia. And secondly, under the Child Act also is very clear under the section 24, which is the authorizations of the management, where the consequences arises that the child is not contactable, so on and so forth, who can give the authority. So in Malaysia, you can have the temporary custody. The custodian can be from the Jabatan Kebajikan Masyarakat, the temporary also from the police, but in those from the school, actually, same like in Philippines, actually the school authority can give this particular consent if it's needed to do so. But if there is an issue even for that, so the doctors actually can make that particular decision in order to provide the necessary treatment. So meaning the key word here actually that I need to address, whatever decision that we made with regards to providing care to a child or to the minor, they must be under the premise of the best interest of the child. So in whatever ways actually that need to be addressed accordingly. So that's my comment on this.
Is anything to add, Dr. Makarina?
Yes, I'd like to add that the state has the authority also to take care of its citizen. The child is a citizen after the substitute parental authority in the school officials. It's the state. So in the Philippines, this situation is referred to the DSWD. Thank you.
Thank you. Okay, maybe I would want to add another question, because would it make any difference if the child is 16 or 17? Like in the West, we have giving competence where they listen to what the child wants. So maybe I would want to ask, in Malaysia or Philippines, are we going towards that, giving a child more autonomy in deciding something, or we still stick to 18? What do you think? Dr. Mahada, maybe?
Gili competence is something that can be applicable when the child reaches an adolescent age group. What is the adolescent age group? Meaning the child can decide what's right, what's wrong, what is the best interest for them. So Gilead competence is only a guide based on the case law that by Gilead that making that particular decision. Either the court in Malaysia actually utilize that, I'm not sure, but I do believe there are such cases where actually they refer to that what I call test in order for them to make sure either the child really understand or in the position to make decision for him or himself. So that's my comment on it. I think Hafiza, you should know better about this. I think probably if you can provide the necessary case law with regards to this in the Malaysia setup. But the principle is the same. It's not just 16, it can be 12, it can be 15, it can be 13, as long that in adolescent age group, actually the law, I think, in fact, there is one case, I think you remember previously, the criminal involving a penal code, where actually 11 years old boy actually shoot somebody. Remember? That was a few years back. All right. So there was an issue either that the boy, the 11 years old boy should be tried as an adult or as a children. There is where actually the court of law in Malaysia actually they decide either this child actually can be as a child or had to be an adult. I think at that time the decision was the child, the boy to be trial as a minor rather than as an adult. So in that particular case, such scenarios actually has been addressed.
Well, in the Philippines, it's quite strict. 18 is or below 18 is the age of minority. So there are other things that you cannot do when you are still a minor. Of course, we have our laws also that take into consideration the age of the child. So that the discernment in the Philippines is equated to the age. Thank you.
Thank you. So we have few questions from the participants. Let me just read them. Okay, first question from Tan SY. If a patient calls for ambulance help, waited for an hour for the arrival of ambulance, then subsequently the patient becomes unconscious and pulseless on arrival to ED. The family wants to sue the hospital. What would be the next step to handle this case, and would the hospital be liable? So, any Dr. Mahada or Dr. Makalina want to take? Or can repeat?
Dr. Malik Makalino off his video, so I presume I need to answer first. Never mind, I put my comment on it. So first and foremost, the family wanted to sue the hospital. Yeah, carry on. We can't stop people suing. I think that's the right of everyone to sue, right? Secondly, what will be the next step to handle the case? Again, like any other complaint, this is where actually the organizational governance actually to handle looking at the case. What is this case all about? The validity of the case, the facts of the case, so on and so forth. With regard to the an hour that being addressed here, either that hour, 1 hour is a time critical to determine in terms of the outcome. If the answer is yes to that, then the second question being posed, either there is a policy with regards to such a case where actually the ambulance have to come certain periods of time. So if they can't come within a certain period of time and there is a clear justification onto that, this is where actually we can justify the reason why there was a delay. So of the ambulance arrived to the site. So that is very difficult because it's involved many other variables actually or conundrums that need to be answered. Either that 1 hour delay is an important event or what I call the omissions of care that leads to the morbidity or mortality later to that particular patient. So that question needs to be asked first. And the last question, will the hospital be liable? Yes, if, as I said, so because in Malaysia setup, the Ministry of Health is the highest. People won't just what I call sue a particular doctor in Malaysia if they work in the public hospital because the doctor do not have any money. Who have the money? The government of Malaysia have money. So the Ministry of Health has the money. So they will sue the first defendant will be the Dr. A, the second defendant will be the specialist B, and the third defendant will be the hospital himself. Why they sue the hospital? Because they know the hospital have the most money that come from the government. So is it liable? Yes. Later on, when actually if it's proven there is an elements of negligence, and there were actually based on the balance of what I call probability, what sort of liability will be incurred to the hospital, to the first and the second defendant. So that's how the process are when there is actually a medical negligence or medical malpractice occur. So that's all I can comment based on this particular question. Thank you.
Dr. Makalina, how about Filipino situation?
Yes, here in the Philippines, the ambulance system is practically conduction, except for some areas in the country like Davao, when Dr. Benedict Valdez is doing such a good job, and certain radius from the PGH, and so many, and some more areas. But then it's practically conduction. So if you want the ambulance, just like what we watch in TV, the 911, then probably this ambulance will be delayed. So there's not many cases that is progress in court as regards to complaints against the ambulance service and probably the ambulance doctor or the hospital. So it's just an sad to say, but then it may be this is another area we'd like to improve on. It is an acceptable fact that there is delay if you take the ambulance, such that you just use it for conduction. Thank you.
Thank you. So we have another question. I think a bit more time. So the second question is about wrong medication. So Nick Shuhada is asking, there is a trauma patient who was given a wrong dose of antibiotics. The patient did not have any complications, and the error was explained to the patient as we needed prolonged observation. The patient understood, and few days later asked the doctors for monetary compensation. So how do we approach this matter? Maybe Dr. Macalino, what is your
Yes.
opinion on this?
Antibiotics is not so bad. Usually, the dose that you are giving in terms of the initial dose, you can double it. In most of the antibiotics being given, what is bad enough is that of the contrast during procedures. So these are sensitivity reaction happen, and there are many persons, patients who die because in the process. So for antibiotics, well, generally I think the patient would recover. The more important thing is, do you disclose to the patient? Yes, offhand, if there is a event such as that, we do complete disclosure to the patient after investigation, and then leave it to the patient whether he or she would want to further investigate or further bring the matter to court. Then we do investigate. What we are afraid of is double doses, triple doses of contrast. Thank you.
Dr. Mahada, any comment on wrong medication?
I just very simple comment. Actually, if you look at the statistics of medical error, I think the top 3 is medication error. But remember this statement: not all medication errors amounting to negligence. This is two separate things here, right? Because as I said just now, in order for you wanted to label somebody as negligence in their act, you have to fulfill about 4 elements that I mentioned earlier. So not fulfilling that elements, you cannot pass somebody as what we call negligent. In this particular case, yes, we accept the fact that there is a wrong antibiotics or wrong medication given. There is a medication error, but this medication error does not lead to any significant harmful effect or damages to that particular patient. So I think what important here is the disclosure of information I mentioned by my esteemed colleague just now. And then number 2, actually, with regards to how the institution governs or relates or what I call address this at the levels of the hospital. And one thing that was posted in that question, so how that they wanted to ask for monetary compensation. This is where actually during the interaction after the disclosure of information, we have to put it very clear in such incidences, especially in Malaysia setup. There's no monetary compensation actually allowable actually for them or to be given to them. So unless there is a significant harm or injury, for Malaysia, even in order to do that, they have to go through the whole process of the internal and external inquiry and up to the what I call committee for the ex gratia or compensation to give to the patient. So that's the way how it works in Malaysia. Thank you.
Thank you, Dr. Manda. Thank you, Dr. Macalino. Thank you for the questions. I hope these 4 cases have highlighted some of the recent and upcoming issues that we are handling during our daily practice. And I hope we have got some view on Malaysian and Philippines medical, legal, and ethical practice. So thank you very much for our panel. So I pass back to Dr. Faith.
Dr. Hafisa?
Yes.
Yeah. I'm just interested in the first case. Was that disclosed? What happened to the patient? Or that's not part of our...
Actually, it's a fictional case, but I think whenever something iatrogenic happen to trauma patients or in that fact non-trauma patients, it would be advisable for us to disclose to the patient,
Disclose.
definitely. Or Dr. Mahada wants to give
It's
another answer.
Dr. Macalino, that
Yeah.
first case actually is a real case, but not in my institution. It happened in one of the institutions that I worked a few years back. So the patient survived. That, of course, after that, followed by an inquiry, and the authority, we have to give the patient the compensations actually because of eye-threatening injury. So due to the chest tube incision that passed through the liver to the diaphragm and also causing an unnecessary damage to the patient. So it's a true case. Yeah, few years back.
Do you advocate full disclosure or
There's
any
still
form of disclosure?
there's a political that's the what I call the 1 million question that need to be asked. All right. I think when we do a disclosure, there is a guideline of a disclosure coming out from the Ministry of Health with regards to this. Malaysia actually in the middle of developing what I call law according to this, and at the same time looking into the various factors, because I think we understand what you have mentioned just now. The article they put forward during the initial presentation actually is quite a while already. Since then, there's a lots of what we call cases or incidences that occur in Malaysia that leads to significant damages being given to the patient. Even up to now, what we're saying that the numbers of the amount that we're given to the patient, the damages is very substantial now in Malaysia. So that's why we're very careful actually looking into that. And last but not least, I wanted to highlight also, though that for Malaysia, for medical malpractice, the main principles are actually under the law of torts, but under the law of torts, actually there are many acts and also involve some criminal components as well to it as well. So that's my last comment. Thank you very much anyway for the opportunity given to have this discussion this morning. Thank you.
Thank you very much.
Thank you. Okay,
Thank you very much to all our panelists, Dr. Macalino, Dr. Mahatar, and Dr. Hafiza. Allow me to give our certificate of appreciation to the group. So the certificate of appreciation is awarded to Dr. Mahatar Abwahab, who has contributed as invited speaker to this mascot trauma series held this 20th day of November 2021, signed by Dr. Shah Hazan, Mod Yusuf, and Dr. Norzan. And the same certificate is awarded to Dr. Joel Macalino, and also to our moderator for this session, Dr. Hafiza Zainal Abidin.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you so much, doctors. And now we have come to a very important event or part of this webinar. And this is the signing of the Memorandum of Agreement between the University Technology Mara and the Southern Philippines Medical Center. This collaboration has started in 2018, and this is the second Memorandum of Agreement that we are signing. And as we continue to develop our trauma system in both countries, the collaboration is very important. Kindly watch this video.
ready for it. Get ready for it. Yeah, this is it. Yeah, this is it. Yeah, it's about to break. Got what it's gonna take. Go ahead and on that stage. Let's go. When you're made for this, yeah, it's obvious. Top another list. Let's go. Get ready for it. Get ready for it. Get ready for it. Yeah, this is it. Yeah, this is it. This is it. It's now or it's never. No plan with forever. It's now or it's never. Yeah.
In the development of a trauma system in a country or in an institution, it is important that different departments and different specialists would collaborate in terms of trauma care. Creating a culture of excellence through research and policy making towards a better and efficient and effective trauma care in a hospital is very important in terms of the survivability of our patients. And therefore, in terms of education, research, policy making, as well as protocols and guidelines in trauma care for our patients, a collaboration between departments, specialists, is the rate limiting step of a successful trauma system. The role of the emergency medicine and trauma surgeons in the emergency department is to focus on the different cases at the ED, especially trauma cases. The intricacies in terms of coordination and its critical role in resuscitation would make a difference, especially the trauma physician and trauma surgeons are working together. It is inviolate for an institution without these specialties because it entails efficiency and effectiveness in the department.
Hi, hello, good morning. My name is Dr. Shah Jahan. I'm the head of the Trauma Physician and Subspecialty Training Program. Welcome everybody to this event. How do we measure the outcome of the trauma program? I like to look at it as two prongs of measurement. One is going to be the clinical quantitative method, and the other one I'll look at it as the qualitative aspect of measuring the outcomes or the impact of the trauma program. In the quantitative aspect, we look at numbers and data. We like to see how the impact of the emergency trauma care service with the subspecialty training and the trauma program system has an impact on reducing morbidity, mortality, complications, and as well as improving outcomes as a whole. And of course, this takes a duration of time and also a back-end system to be able to collect data. And we're happy to have launched the Malaysian Trauma Registry recently, collaborating more than 15 centers in being able to submit data for simply this purpose, and as well as utilizing this data in the near future to create a survival prediction model for the cohort or local cohort of our patients. And this is one of the quantitative or more objective methods of assessing the progress and outcomes of the trauma program, of which we really look forward for, and it's also a tool, what we call it as the eye to guide us for the future, to see where we're heading, what are the gaps that we have, and etc. The other more perhaps fun method of assessment to look at the impact of the trauma program will be the qualitative wing. Qualitative aspects of assessment will encompass peer reviews, peer recognitions, interspecialty collaborations, interspecialty networkings, as well as clinical partnerships that we are able to forge within the time frame of our service development. Another aspect of progress can be also gauged with the buy-in or the development of interest among emergency physicians into embarking into subspecialty trainings of what we see today, increasing number of trauma physicians as well as increasing number of trainees within the program, and we are happy to look at that as one of a positive measure of progress that we have, and we look forward to embarking into bigger numbers and expansion of services as well. Also looking into increasing number of dedicated trauma services within the emergency departments, as well as having higher number of local and also domestic and international training centers for our program. Today marks a very important day commemorating the partnership which is regional in nature between SPMC as well as the UITM trauma program, where we celebrate this occasion, and we're happy to have the trauma program replicated not just within the nation but as well as within the region, sharing with our twin sister partners in SPMC. And together we feel we will definitely be more effective as well as be able to achieve our aims and targets of improving emergency trauma care services at the front end to leap faster towards that direction, and not just increasing or benefiting both our nations but the region as a whole. I also do look forward that this partnership between us will stem future collaborations from even other nations to join together in hand with us in increasing further or developing further the trauma program in emergency medicine, moving towards future. At the end, we need to look at the infrastructure, system and clinical approach method that we perform, and we hope and pray that the end client, which is the patient, is going to stand to benefit the most. Ladies and gentlemen, I thank you again very much for having me, and let's make it happen. Have a good weekend. Peace.
Dr. Sabaria, can you tell us the initiative steps taken before commencing the Memorandum of Understanding back in 2017 until the recent Memorandum of Agreement is being signed? And what are the most memorable memories that you could share with us?
Okay, thank you, Dr. Amira. Hello everybody. Assalamualaikum warahmatullahi wabarakatuh. I have known Dr. Faith and Dr. Poli for quite some time. We've met at some conferences overseas. So we did talk something about trauma program. And during the EMAS meeting, that is the Emergency Medicine Scientific Meeting in 2018, Dr. Faith introduced me to Dr. Benedict Valdas, who is the trauma surgeon in charge of the emergency department at the Southern Philippines Medical Center. So we got talking about trauma care, and he was talking about the development of the new trauma center over at SPNC in Davao. So at that particular time, we, the Ministry of Health Malaysia and UITM University Technology Malaysia has trauma physician fellowship program. So we discussed about it, and then we offered them for their residents to come and do some form of training, trauma training with us, and even to take part in our trauma fellowship program. So it actually started from there, from the EMAS
2018. And as things progressed, in 2018 during the Malaysian Trauma Conference, we had we signed a letter of understanding or agreement between UITM, the Ministry of Health, and the Southern Philippines Medical Center. And we progressed from that, and we had we had a workshop on the trauma center development where Dr. Shah and I and Dr. Mada, we were invited to go to Davao for the discussion. And as of this year, we had a series of trauma continuous medical education online that we do once in 3 months in conjunction with the Malaysian Society for Care of Trauma, MASCOT, UITM, and the SPMC, which we do together with our colleagues in SPMC and the Philippines. So those developments were very exciting to me, especially meeting Dr. Ben Valdez, Dr. Faye, Dr. Pauline, and other conferences to further discuss how the trauma program and how we in Malaysia can help Philippines or Davao and SPMC to develop the trauma fellowship program, especially in the field of emergency medicine. So we do look forward for further cooperation, and with the memorandum of understanding that we have recently signed this year, I'm sure that there will be further collaboration between UITM, Ministry of Health, MASCOT, and also with the SPMC in Davao, Philippines. Thank you very much and have a good day, and we will see each other again. Bye.
Thank you, Dr. Sabaria.
Now, we'd like to call on the Deputy Director for Hospital Clinical Support Services of University Technology Mara, Dr. Izzat Ismail, for his message.
Our guests of honor, Dr. Valdez, Dr. Garland, and the management team from Southern Philippine Medical Center, Professor Sabaria from UITM, and Dr. Shah Jahan from the Ministry of Health Malaysia. Distinguished guests, ladies and gentlemen, greetings from University Technology Mara, Malaysia. It is my great pleasure to extend a warm welcome to all of you that are present here today to witness the exchange of Memorandum of Understanding between University Technology Mara, Malaysia and Southern Philippine Medical Center. My highest appreciation goes to the management team of SPMC for this opportunity for collaboration between our institutions. The Memorandum of Understanding that will be exchanged today will establish a strategic and long-term partnership between UITM Malaysia and SPMC. I share the optimism of wonderful possibilities as our institution enters this partnership. Ladies and gentlemen, UITM from its humble beginning has earned its place by providing the highest quality education and training for Malaysian and candidates from overseas. It has since grown into the largest institution of higher education in Malaysia. Our university has now comprised of 35 campuses and 3 teaching hospitals. We are now home to 150,000 full-time and part-time local and international students ranging from all aspects of education, including medicine, dentistry, allied health, engineering, arts and design, and many more. Our teaching hospital, in collaboration with the Ministry of Health Hospitals, provides students with opportunity to pursue undergraduate and postgraduate training, including fellowship programs. I believe with this collaboration will enable us to explore training and opportunity, especially in the field of medical sciences, that will benefit both countries. Ladies and gentlemen, with the current situation, no single institution, no matter how well established it is, none can address future challenges by itself. Thus, this era of collaboration and cooperative partnership with other institutions of academic excellence around the world is not an option, but a necessity. Our vision for continuous excellence is to invest resources to enhance knowledge with wide-range collaborative effort to meet these new challenges and maximizing opportunity for the benefit of both institutions. This Memorandum of Understanding will commit us to work more closely together towards our common goal, towards the internalization of medical education and training. We hope to engage in many activities, not just virtually, but physically when conditions allow. Once again, I would like to express my gratitude to friends, colleagues, and the management team from SPMC for making this Memorandum of Understanding a success. We look forward to translating the words in this Memorandum of Understanding into action. Thank you very much.
Thank you very much, Dr. Izat, for that message. Now we go to the message of Dr. Benedict Edward P. Valdez, the Chair of the Department of Emergency Medicine, Southern Philippines Medical Center, and Chair on the Committee on Training for Trauma for the Philippine Society for the Surgery of Trauma, to deliver a message in behalf of our Medical Center Chief, Dr. Ricardo Audan. Dr. Valdez.
Good afternoon, everyone. I hope you can hear me clearly. This day is a momentous day that we signed our hearts and minds towards a better edifice of progress in terms of trauma care. The trauma system in each country has its ups and downs and tug of wars of the different developments and challenges along the way. And we have come into the realization that trauma system and trauma care can be very efficient even amidst pandemic. But on our part here, as your partner and as your colleague that would promulgate the best trauma care, not only in Asia, but in the world, we are developing our hospital towards a better facility where the upcoming trauma center, which is 250 bed capacity, including burn units, neuro ICU, pediatric trauma care, as well as the trauma physician emergency medicine department, will bolster its hardware and its software with its clinical skills and acumen among those participating specialists and our training fellows within and coming from abroad will be realized. With this memorandum of agreement, it is actually the rate limiting step of any endeavor, the providing the very best meeting of the minds of the clinicians as well as the forerunners of trauma care in Malaysia and in the Philippines. As for the moment, the Philippine Society for Surgery of Trauma has come up with a curriculum for surgeons, the trauma and critical care, which is the Southern Philippines Medical Center will be launching first quarter of next year. In a parallel situation, This memorandum of agreement will bolster also the launching of the Trauma Physician Fellowship in Emergency Department, and the same target by next year. The target of the Department of Health Southern Philippines Medical Center, that the implementation of its facility is between 2021 to 2025, where they have allotted over 5 billion pesos developing 5 major trauma centers in the Philippines, 5 major institutes in Southern Philippines Medical Center. So that's why I think what we are doing here is actually a benchmark, not just about the trauma care, but there's a better collaborative efforts between nations, between Malaysia and Philippines. And right now, in behalf of our medical center chief, Dr. Ricardo Audan, and those different departments in Southern Philippines Medical Center, we welcome this memorandum of agreement. And this is one among the many factors. That's why Southern Philippines Medical Center will be the apex hospital in Mindanao. And thank you very much. And I hope everyone is safe and healthy, because we still fight COVID-19 in our country. Thank you, and good day.
Thank you so much, Dr. Valdez, for that message. Now, in behalf of the Southern Philippines Medical Center, Department of Emergency Medicine, we would also like to present our token of appreciation to the University Technology Mara. Thank you very much, Dr. Valdez. And I would like also to call Dr. Izzat Ismael for University Technology Mara.
Thank you so much, Dr. Garland, and thank you, Dr. Valdez, for such a powerful and kind words. On behalf of University Technology Mara, we'll be presenting a garment, a traditional garment called songket. As many of the viewer knows, because we're local within Southeast Asia, songket is a traditional costume which are native to Malaysia, Indonesia, Singapore, and Brunei. Usually, historically, it's been used by royals, but nowadays it commemorates a ceremonial use, for example, during festive and also weddings and traditional events. So with this, I would like to honorably present you. Okay. The color is purple because our university color is purple. Okay. So
thank you so much, Dr.
Next time we meet, I will present you physically, but at the moment virtually. I thank you again, Dr. Garland and Dr. Valdez and the team from Philippines.
Thank you very much, Dr. Ismael. And at this point, may we ask our colleagues to open their cameras so that we can have a picture taking, commemorate and remember this important event. Dr. Sabaria, Dr. Mahatar, Dr. Valdez, or Dr. Perez, Dr. Convocar, if you're here, Dr. Norzan, and our panel speakers and our speakers for this conference, Dr. Yap, Dr. Roman Cap, our organizing committee, Dr. Nerzan, and members of SPMC, UITM, and Hospital Sungay Buloh. Thank you very much for opening your cameras. I will now take a picture. One more. Congratulations to all of us, and hope this collaboration will continue and will be more fruitful as the years go by. Now I'd like to call on our executive officer from the Department of Emergency Medicine, Dr. Johnny Perez, for his closing remarks.
It's a good noon to everybody. I'm presuming we have the same time in Malaysia. I am tasked to give the closing remarks for this wonderful session. And I'm just wanna thank especially the presence of Dr. Izzat Ismail, Deputy Dean of Clinical Support Services in University Technology Mara, Malaysia. Thank you, sir, for signing our memorandum of agreement with SPMC. It is really an honor to have a collaboration with you. And I'm seeing friends and colleagues here from Malaysia as well, Dr. Shah, Dr. Sabaria, of course, and Dr. Mahatar, and to my friends and colleagues here in the Philippines as well. We thank you for this session that we had the whole day this morning. And we're hoping that we'll be seeing each other again soon. And the challenges that we face as we move forward in this collaboration, especially when we identify these challenges as in the areas of manpower, in the areas of facility enhancement and development, in the areas of national and local government support, and through legislation. These are all needed for us to really move forward in our quest for better systems, especially particularly the trauma systems in our localities. And we hope and pray that all this will come, particularly as we move forward, surpassing this time of pandemic. I love the comment of Dr. Shah a while ago in his message, wherein we want to have other countries as well to join us or to collaborate with us, no? In this endeavor, no? To collaborate with us and through us. And with this example of collaboration, it is really a thing that all of us here in the part of the world, in Southeast Asia, would be a shining example of unification beyond the religion, beyond race. No? And we are oft after the welfare of mankind, particularly the area of trauma. And this is an example of that, this form of collaboration. Again, with the help of God, the help of Allah, we will help this as a beacon of light in both countries, particularly in Malaysia and in the Philippines. Thank you again so much for joining us this morning for our trauma sessions. And we're hope to see you again face to face, hopefully very soon. I hope everybody is protected well in your families. And have a good day to all of you. And may you have a good health and always be blessed by Allah and God. Bye-bye, everyone, and thank you so much. Faith?
Thank you so much, Dr. Perez, for that closing messages. And this ends our webinar for this morning. And I know that it is a very fruitful one. And because we have also marked in terms of our history, this collaboration between University Technology Mara and the Southern Philippines Medical Center for more improved trauma care in Southeast Asia and in our countries. Good morning, everyone.
Good morning and bye-bye.
Morning. Bye-bye.
Morning.
Thank you, everyone.
Good
Thank
noon,
you.
everybody.
Bye.
Thank you very much.
Bye. Safe,
See you guys
Have a
everyone.
good
tomorrow.
day.
Thank you.
Everybody,
Bye. Thank you.
take care. Be safe.
Be safe.
Thank you. Thank you.
Screen share.
Thank you so much, Dr. Ismael.